Vladimir, good afternoon. Hello, Stefan. Ciao.
I was on mute.
Stefan, hello.
Hello.
How are you doing?
Hello, Vladimir.
Hello, Johnny.
How
How
are
are
you?
you? Hi. Good to see you again. Ramesh.
Hello,
Hello.
long
Hello,
time.
hello.
Hello, hi, Johnny and Stefan.
Hi.
Girish,
Girish.
Hi, Ramesh.
Hi.
Hi.
good to see you.
I'm Vladimir.
Hi, Girish.
Right.
Great. You are the first, Giovanni.
Yeah. And whenever you decide to start, I may get in.
Right.
Hayek,
Ek.
Ek.
Oh.
I'm just finishing off another MDT. I'll be joining back soon. I think who's sharing the first session? I think Imad and Vladimir, right?
Yep. Right.
Okay, I'll come join later. But
I
I'll
miss
be
Imad.
back in. Huh?
I miss Imad.
Yeah, we haven't seen him yet, but
Yeah. Who is hidden behind this international academy?
probably Pablo.
Pablo, probably.
Yeah.
You are right.
We can't hear you, Ek.
Ek, unmute.
I was super excited this morning to upload some new MPV4 video clips to my PowerPoint. The whole thing died. So I was up all night to try to refix it, but we'll see what it does. This is one of these
Yeah.
events where you think like technology, every file is a gigabyte and PowerPoint didn't handle that too well. We'll see. But I'm excited to see you all. Very happy.
Me too. I have the
Yes.
same problem as you. I have the presentation uploaded, and when I switch to the presentation mode, it shows on my screen, but not on the screen of the rest. So I hope this will work today.
Yeah.
Yeah, the techniques is always mysterious to me.
Exactly. Exactly. I think I need to change my name here. I don't know why that has.
I wonder where is Imad?
Enjoying the sunshine.
Most likely 50 degrees or something like that, what they have now. So, Giovanni, what do you think? Shall we give it 5 minutes or?
Yeah.
Ah,
You want-
okay.
When as soon as you decide, I can share my screen.
So let's give it another 2-3 minutes and then we shall start.
Okay, very good.
Abida, hello?
Good to see you.
Hello.
Well, you do not need to think, you can talk only.
Yes, good to see you. Hello, everybody.
Hello?
Huh?
You're not on video whilst you're driving. Come on, be honest here.
Why don't you show us some outside, some slides?
No, I'm just getting home in about few minutes. Then I'll join back from the computer.
Very
Hi,
good.
Abida.
Hi,
Well,
Dr.
you-
Girish Menon.
Short time you have a lecture. It's like 20 minutes, 30 minutes.
How many minutes? 20 minutes.
Right, there is Johnny, Paolo, myself, and then you. So you got something like 30 minutes to be home.
No, I'll be home in another 7-8 minutes.
Okay. But be prepared because my lecture may be difficult to show. So you might step in.
No problem. No problem.
Good. All right, I don't know about Imad, but Johnny, we probably
Yeah,
should start.
maybe you want to start off, Vladimir.
I
think
will.
Imad is-
I will. All right, welcome everyone for the next International Academy of Neurosurgical Anatomy seminar. Today we are going to be discussing, let's say, intrinsic lesions or the lesions within the brain, unlike what we did mostly in the past, the outside extrinsic like meningiomas and schwannomas. Now it will be really intrinsic lesions, and I have a very big honor to ask Giovanni Brogi from Milan to give his lecture on disconnective surgery for epilepsies, hemispherectomy or hemispherotomy. Giovanni.
Okay, thank you. I try to share my screen. You see it?
Yes, go to presentation mode.
Yeah. Okay. Did you
Okay,
see? Okay.
perfect. Perfect,
Okay,
Johnny.
so,
Go on.
Vladimir, thank you for giving me the opportunity to be the first one on this very good session. I am talking about this connective surgery for epilepsy. That means that the lesions stay there, the lesions that are causing epilepsies, seizure, but we can take them in a corner and leave the patient without any clinical problem. So I have nothing to disclosure. The history. There was, the idea of take out a part of the brain with the disease is very old. It's 100 years old, but then they proposed to take out half of the brain with the gliomas, and that was the time of tumor period. And after we came for the seizure, and you can see there was a functional period, but there was some problem with the hemosiderosis, that is a complication that we discussed later on. And after we started with modification, the anatomical hemispherectomy, to go to the functional hemispherectomy and to functional hemispherotomy. So this is one case of the dentist. You see here that he take out almost all the brain, the hemisphere, with the glioma inside. But that was a lot of complication, and so it was abandoned. Also because glioma in many cases multi-center. And after we went to the hemispherectomy for the seizure and for other type of disease, like infantile hemiplegia. You see here what was proposed with the resection also of the basal ganglia that was making a lot of complication later on. This is one of the scheme in which you see here that the dura or membrane is tied up with the part of the brain the ipsilateral part of the brain remaining. And this is a post-operative control. And these are the results. And you can see here that the results are not so bad. I will say that are quite good, because it's running from 50% to 90%. But the very most cases, and you see here that there is one case of hemosiderosis, and out of 50, there was 15 cases of hemosiderosis. It is a complication that may become later. Complication, as you see here, the hemosiderosis can come out also later on in the time, and is not only tied up with the hemispherectomy, but also from other type of pathology. What is hemosiderosis is a kind of the deterioration of the brain. You have to understand that there is a healthy hemisphere on the other side, and the chronic ependymitis so is a problem. Incidence. You see here about 24% in a different series in different center. This led to the abandon this type of anatomical hemispherectomy. And so what came out afterward? The partial hemispherectomy, hemidecortication, but the most important, the functional hemispherotomy and hemispherectomy before and hemispherotomy later on. What does this mean? Hemispherectomy, it means that you have to take out one part of the brain and disconnect the central lobectomy to completely differentiate the lesional part of the cortex. This is the schema, and this is what Rasmussen series show, taking out completely this part of pathological brain. Seizure control, again, Rasmussen series, Montreal series, you see 86% for hemispherectomy, and 68% for hemispherotomy, but no hemosiderosis. So that is the way the things were moving. Functional hemispherotomy, and that is something that we are talking, and I report our experience. You see here at the best indication, the same indication of the previous one. That means one of the contralateral hemisphere should be seizure-free, and that is the way that you can perform this. And we show you other technique to perform this differentiation. Indication: lateralized hemispheric intractable epilepsy, of course. The contralateral hemiparesis, because that is something that you have to understand, that the function of the end is almost always lost. In some children, it can come back because of replication on the other side. The indication: the cortical developmental malformation, encephalopathy, peritoneal stroke, Rasmussen and Stuga-Weber, and we see later on. The pathology is, if it's focal, we can make focal cortical resection or cortical differentiation. Otherwise, that is the way to perform this kind of surgical approach. Remember, the MRI is not bringing the indication. The indication is the clinical. The cause of seizure, the symptomatology of the seizure. Of course, today we have the scan, PET scan, to see what is if the other hemisphere is working properly. The only things that we suggest in our experience is early surgery, because control of seizure make completely different quality of life of the patient, and mainly when they are younger age. That is what we have to do in this scheme, and the reference points are pericallosal artery, the perinsular artery for in the ventricle, and the choroidal fixture for the temporal lobe, and mainly for the insular disconnection. And this is the scheme you see here, how to perform it, and that is the post-op that we can see. And the only very important things is try to respect the ventricles, and so mainly the arterial blood supply. There is different technique. Vilmuren and Schramm proposed the lateral approach, and the one that we follow. Schramm modifies following the arterial cistern. Other type of disconnection. The most important thing is Delaland introduced the vertical disconnection here. You see getting into the ventricles and taking the respect of the basal ganglia. So navigation in the planing is very important because it's an anatomical approach. And of course, today the DTI is quite important because tell us if all the fascicles are correct or not. Indication. Some indication are congenital disease, like the megaencephalopathy, or the cortical hemispheric dysplasia, when the dysplasia is taking place in all hemispheres, like in this case, Stuber-Weger. But the acquired indication are very important because, as you will see, the results are a little bit different. Perinatal stroke, the chronic encephalitis, Rasmussen syndrome. And that is Rasmussen syndrome. Today, they found out a kind of monoclonal therapy that may be replacing this kind of aggressive surgery. The findings of the Rasmussen, you see here the findings that you find in the specimen. There is a difference between the acquired or the connatal one. you see here in this chapter of this book that better is progressive and acquired than the one that's congenital. The results are different from hemispherectomy and hemispherotomy. The answer is no. It depends, of course, the complication rate, the blood loss, but that is a complication, but is mainly determined by the surgeon and the surgeon's team training. That is very, very important. There is a difference between the lateral versus the hemispherical disconnection, vertical disconnection. That means Gilmour versus Delaland. The answer is no. They are almost completely rate of complication. It can be predicted if the hand has to be lost completely or can be saved or recovered. Yes, there is this paper very important that show how the neurophysiology before the surgery and the anatomical landmark may help the surgeon to propose to the patient the complication. Bleeding and coagulopathy and septic meningitis are the most important things. Bleeding can be avoided or can be reduced. Septic meningitis is present in almost all cases. Plus, we have the risk of flap infection because the flap is very, very wide, and the hydrocephalus, late hydrocephalus is one of the complications. The big problem is that the patient selection should be a monolateral disease. If it's bilateral disease, it's impossible to assure to the patient a complete results. And that is one of the failure. The patient has a bilateral disease and is not well selected. The other things is that the incomplete disconnection. That is the most important case of failure, and it can be reoperated on. The point, critical point of the splenial remnant, the casolar tissue intact, and the frontal lobe is the frontal and anterior disconnection that is very important, mainly if the flap are not so big, and so it's very difficult to get into the front lobe. You see here some residual dysplasic cortical situation. The success of reoperation in any of the series you see here is good, because it's from 20% to 56% in Cleveland series. Our series, there is 2 cases out of 4, if 50%. Our pathology, mainly Rasmussen encephalitis, and only 1 post-traumatic and a vascular problem that is both, this one acquired is both acquired indication. The outcome, Engel 1 and 2, 81% use improvement. That means that they have still to get a lot of drugs. And in 2 cases, it was a completely failure. The most important things is the behavioral and psychological aspect that you can improve, mainly in young patients. That means decrease of aggression and the possibility to go admission to the school. This is the most important advantage of this kind of very aggressive surgery. Complication in our cases, septic meningitis in 70% of the cases, but that is lethargy and loss of appetite, so mainly fever. No death, no hydrocephalus, no infection. But that's around the corner. These are some cases controller post-op in MRI, and I get to the conclusion. The disconnection surgery for epilepsy syndrome that are not, that are not controlled by the drug therapy, or in which the drug therapy changed completely the life of the patient, thinks about young patient, children, they cannot go to the school because they are completely drowsy because of the drug treatment. This can be proposed and is very important. In the peri-insular function that was we have experienced, but also all the other one, the SRAM arterial pericisternal one, and the Lalande, that is the vertical one, have the same results. Is safe and is really very good in control of the seizure. This is our team, as you see, a lot of surgeons, neurologists and neuroradiologists that are very important, because the selection of the patient is a team selection, is not a surgeon selection. Thank you very much.
Giovanni, thank you. That was great. We've got time for some questions or remarks on this procedure and on what Giovanni has proposed. It's probably the matter of few institutions doing these surgeries, since they are really not frequent, and the patient should be centralized, I believe.
Absolutely, absolutely. I think that is today, and now we have also a deep brain stimulation. We have a vagal nerve stimulation that are quite a good type of neuromodulation to control this kind of seizure type in this patient. The only problem is, I think that that's are expensive, and the other one is less expensive. Ethical proposals should not be decided on the basis of money, but we have to understand that in some country, neuromodulation is very expensive. It's almost impossible to reach, and the patient are most time a poor family or average family. And I think that is the problem. It's a tool that in a very good center, or in one center in the country, should be there.
Giovanni, have you ever seen an adult patient who would be candidate for hemispherotomy?
I didn't understand the first part.
Whether you have seen an adult patient who would be...
Yes. Some of in chronic encephalitis, we have two patients with chronic encephalitis. Probably was herpes zoster encephalitis. We have not yet have a patient with COVID encephalitis, but they become.
Yeah. Okay. Anyone else would like to comment?
I have a brief question. Roy Daniel had recently presented the leucotomies to basically use quadrants and disconnect certain parts of the hemisphere rather than disconnecting the entire hemisphere. Would you recommend, in someone who has superficial sclerosis as an underlying disease, I've seen that twice, to get depth electrodes and only disconnect the quadrant that you think is responsible for driving the epilepsy?
Thank you for this question, because allow me to absolutely yes. Today, with neuronavigation, with the scan analysis, we can really disconnect only a quadrant of half of the hemisphere without going to complete this disconnection. And I think the results are very good. Because the disease, you're taking out this, without taking out the disease from the cranial situation, you isolate the disease, a kind of political, let's say, approach, but it's very, very successful.
Guys, one question. See, we've been always following this traditional routes of disconnection, which to say the least, it's maximally invasive. Now I've seen minimally invasive techniques, but I was looking at, I'm not into epilepsy surgery, but I was in a discussion with one of my friends. I was looking at multi-port laser disconnection using thulium laser, multi-port, just not single port, multi-port, but incisions ranging from 0.5 to 1 centimeter. I mean, this laser, the fiber carrier can be, with multiple joints, you can maneuver it, and you could go through the superior temporal gyrus, burn off the amygdala hippocampus, and then you can make a small port at the inferior frontal gyrus, go take off the corpus callosum, superior disconnection, inferior disconnection. So it'll be at the end of the day, you will only have a few wounds here. You will not have a craniotomy. And I mean, I would like to see what is the feasibility, because you guys are into this, and I am seriously thinking whether it can be done or not.
Well, very good point. I think that with the so-called lead light ITT, the laser, you can make a lot of lesion in a strategic point. Moreover, with the focus ultrasound, you can make a disconnection. So we have tools, but I'm not bringing this one because again, laser and focus ultrasound are tools that are not available all over the world at the moment. I think in a few years, that will be the future. So in every place, in every country will be a tool like that. Today, not yet, but I agree with you that disconnection. The only problem with the laser is the connection of the splenium, because you have to make a lot of small, a kind of grapefruit situation to disconnect the splenium.
We can take the, we are using the laser now. We're trying to make some carriers for it, but probably you should know that we can put the laser through the working channel of an endoscope very easily.
Yeah.
So this is something that we are doing, and the thulium laser, you can take it through the working channel of an endoscope, and it's just amazing for ventricular tumors and for, I mean, in open surgery for CP angles and things, and the cuts are very, very precise. So, I mean, I'm sure we'll be, I mean, Manas, other than me, Manas is also using the laser quite extensively now. Our experience is, I would say, very minimal at the moment. But unless we cannot use it for everything, we have to use it for things which are quite safe, and you know that you're not going to screw up.
Okay, we should go ahead, please.
Please.
All right, so let me call Paolo Cadri. Is he with us for the next lecture? Then you probably could have discussed some more. Yeah. All right, if he's not there, so let's hope that he will join us later. And let me share my screen. And I'm going to talk on pilocytic astrocytoma. Someone tell me whether you see my screen.
Yeah, we can see a white screen, Vlad.
Screen, and I'm on the opposite side of the lecture, which is funny. So let me get back. Is it in a regular mode of presentation, or is it?
It's okay.
It's okay. Very good. So
yeah, it's all right. It's all right.
Good. Thank you. So let me talk about the pilocytic astrocytoma in adults, because this is a pediatric disease more or less. But I was just curious how we do with adults. So I collected our patients from the past 20 years. No conflict of interest. Altogether, we have had 53 patients, which is considering that they are all older than 18 years, rather a lot. We divided them into 5 groups, as is usual: spinal cord, encephalon, cerebral, which were most frequent ones, obviously, diencephalon, and brainstem. So this copies pediatric population at all. Those are nice tumors because they are surgical disease. The extent of resection really predicts the risk of progression in adult pilocytic astrocytoma. This is Andrew Nelson. And 5-year survival is 80%. And I would say that this is probably only because the follow-up was short, because from our perspective, the survival of some 70–80% is 10 years, not really something. So spinal cord, we've had 7 of them. 4 were in cervicals, 1 in thoracic. Transition with cervical and 2 in thoracic, which is nothing surprising. There was no gross total resection in any of these cases. Those were subtotal resections, but we've seen only in 1 patient some progression after in the follow-up. This is one of the cases. It says before surgery, the 54-year-old female with dysesthesia. This is like at the end of surgery. These are probably tumor remnants. I cannot be sure, but within the spinal cord, obviously, you are not going down to your blood and you rather leave a piece behind. Out of these 7 cases, this is 8 years after surgery, unchanged, and I really do not know whether this is a tumor or some postoperative change. It doesn't change over time at all. There was only in 1 case some progression of the tumor, but the patient is still doing rather well. He's ambulatory and with normal functions of the bladder and the bowel. So these are rather optimistic. The telencephalic, there were 13 gross total in 10 of these. 1 we've left rather a lot in fornix because we didn't want to damage the patient. And this is only 1 which really progressed, this guy. And now he's beyond surgery, actually some 8 years after the first surgery. This is a typical finding. This is 8 years or 7 years after the surgery. And I believe that these patients with radical resections are virtually cured. This is the one from fornix area when we left part of the tumor behind, and this tumor over the years grew. We then irradiated the tumor with stereotactic radiosurgery. It means cyberknife in our hands, and this is just from the last week, and the patient is in a condition that he's really not fit for surgery, so he's beyond our help. Cerebral, those are probably the best. There was the highest number, 17. There was no progression, gross total into 95% of patients, only 1. And there we have not seen a single progression. This is a nice case of tonsillar tumor, the pilocytic astrocytoma with a typical cyst, the wall of which should be definitely resected. And those are very clean surgeries because you are outside the brain resecting the cerebral tonsil. And this really is surgery which everyone would like because it's a nice approach, nice dissection, nice resection. I believe that for the sake of time, we don't need to see that all. But the central nervous system, except for the tonsil, is completely healthy, undamaged, and the patient is doing well. This is the post-op image. In the encephalic, there are 2 kinds of them. One kind thalamic, we've had 3. And then there are those optochiasmatic or hypothalamic tumors, difficult to localize and difficult to use any sensible taxonomy. We were able to resect 2 of those thalamic tumors. Of course, in those where optic tract is involved, there was no single gross total resection, only partial resections, and it's still a matter of debate whether these tumors are surgical or not. I believe that surgery might help, but you might get well by even without surgery. This is one of the thalamic cases. You see the motor tract, how it envelops the tumor. So it took me some time to find the way. Finally, we decided to go transcortical because I do not like transcallosal approaches. So transcortical, getting into the ventricle and through the ventricle and through the wall of the thalamus directly to the tumor, which was rather straightforward surgery. See the post-op image. There was a remnant which was divided from the mother tumor, but the mother tumor, the big one, was resected. Well, the patient was doing perfectly well. She's healthy, and we then lost her from our follow-ups. She didn't come, and she appeared only last year. And you see that the original site is still clean. The little lesion disappeared, which sometimes may happen with pilocytic. I've seen it 2 or 3 times, but she's got a relapse of the disease in the hypothalamic area. So we've used CyberKnife again for this region, and now we are waiting what will happen. Brainstem, there were 9 of them, and they may be divided into mesencephalic and medulla oblongata pons. Those in medulla oblongata are probably the most difficult to deal with. There we never achieved any reasonable resection as opposed to mesencephalic tumors, where we were able to get a rather nice ratio of gross total subtotal resection. Again, only one tumor at the floor of the 4th ventricle in the pons did grew after the partial resection. So the progression was in 2 patients, one in fossa rhomboidea, one in oblongata. These were the best. This is the mesencephalic tumor before and after surgery. I'm showing it here that this is the only case of sitting position where we had some embolic event. That's a really single case in among probably 250, 300 sitting position surgeries. Fortunately, we got by without any deficit in this young lady. This is another mesencephalic tumor. It's short loss of consciousness. The lady came to us. Again, the same transcortical approach into the lateral ventricle and along the tela choroidea, lateral to the plexus, directly to the tumor. We were not able to achieve radical resection in this case. See what we did. This is a tumor remnant which is stable over the years. The girl is perfectly healthy without any deficit. Now it's probably some 8 or 9 years after the surgery. So what do we know about pilocytic astrocytoma? It's mostly from pediatric population. The discussion about BRAF alterations are rather frequent, and all the articles only conclude that it's possible, probably, maybe in future, and so on. So as of now, we only are able to get a prognosis. We have no treatment modality for these tumors at all. There is this BRAF V600E mutation, which is really positive factor for overall survival in pediatric population. Don't know about the adults. The alternative treatments were proposed by Ton in Munich, who used this intracavity radioactive seeds with not really promising results, but he's been doing it for many years. I don't think that anyone is continuing his work as he did it at the beginning of the century. So how to conclude the pilocytic astrocytoma? It's definitely dominantly pediatric tumor, not really frequent in adults. Progression in adults after radical subtotal or even partial resection is rather low. It's 10%, means 5 in 53 cases in our hands. We've divided them into these 5 groups. So the tumors are, let's say, everywhere, all over the central nervous system, and the best are the cerebral, then telencephalic. We've had very good experience with spinal cord tumors. Those diencephalic and brainstem are much more difficult. Optochiasmatic is still a matter of debate. In brainstem, much more optimistic from surgical point of view were those in the upper brainstem, in mesencephalon. Of course, resection radicality matters, and since PA is a surgical disease as well as ependymomas, we should be rather active. This is my opinion, maybe, of course question. The approaches are individual because the tumors are everywhere, and we always resect whenever possible the cyst wall, since the tumor usually is in the cyst wall. What's surprising and nice that those are the dynamic lesions. We've seen after the surgery, after partial resection, that the tumor is really changing its shape, its volume. The cysts are growing, then they are getting smaller. So it's not always the same image. And there are tumors which disappear, like the one which I have shown you in the thalamus. So really the MR image is not important for indication of surgery. Those are the clinical symptoms. I wouldn't dare to operate on asymptomatic tumor. It has no reason in my mind. So really the clinical symptoms and only then MR to indicate the surgery. Thank you very much for your attention. Okay, let me close the presentation.
I think Vladimir may have accidentally signed off.
Because I was at the end, I was disconnected.
Yeah.
Yeah.
Now I see you. It's good. You're back.
Very good. All right. So, Egg, why don't you chair the discussion for me? Because it would be ridiculous for me to yeah.
So thanks for a great talk. I think this remains one of the interesting challenges. These tumors, as you have shown, are located throughout the brain, and surgery remains, I think, the treatment of choice, because if you accomplish a gross total resection, you can actually, in many cases, accomplish a cure. And modern ways of adjuvant chemotherapy with BRAF mutation inhibitors are still in the experimental phase. I don't think anything has been established, but I was interested in that case where you showed the recurrence in the hypothalamus after you had done a previous resection. How do you think the tumor spreads? Because that remains a mystery for me in pilocytics. You know, some of them are so well contained, it's almost like local disease, and others follow more glioma path and are infiltrative. Just a comment on that one.
We've seen another case like that was optochiasmatic tumor with which we fought. That was one of the most difficult patients we ever had. And the boy developed another tumor in the occipital region, in the trigone. I'm not sure whether those are really part of the original tumor. That may be another growing tumor given by the genetics of the patient. That's somehow my idea. And what's
there clearly is no spread from dissemination during the surgery.
I don't think so. I don't think so. That is a spread. Virtually, both of these tumors, which we've seen as a second tumors, were along the CSF pathway. You know, the hypothalamic one was the same. The occipital tumor, which we've seen in the trigone, again, it was along the CSF pathway. So spread via CSF, I don't know if I can imagine that, but would be the only explanation. And then there is another point which I didn't make during the lecture, that if you resect the tumor partially, the remaining tumor may even decrease in size over the time. It's something like, you know, it's stupid, but you harm the tumor and it gets scared and decreases in size. It's not much scientific what I'm saying now, but that was, the tumors are really dynamic.
Yeah. No, thank you for that presentation. I do want to comment on your brief mentioning of interstitial brachytherapy that the Munich group used to do. Fritz Kret was the neuro-oncologist who learned the stereotactic seed implants in Freiburg, where I trained as well. I think it is worthwhile as a local therapy mode, because although it's invasive, you can create an incredibly high dose concentration at the site of the tumor. And instead of resecting a thalamic glioma, let's say, I'd say that's a smart way of delivering high dose, but it can be delivered these days by CyberKnife, which is one step less invasive. So I see your point.
As far as I know, those were iodine-based radioactive seeds which produced alpha rays. So it was not really like gamma rays delivered by CyberKnife. Those were really local seeds and local irradiation. And Ton was doing that for many, many years. in pediatric population.
Yeah, yeah.
I do not know if anyone is still continuing in this work.
There used to be the group in Köln that did interstitial brachytherapy as well. That was Voges and some others a while ago, but I don't recall it right now either. In the United States, you cannot use the IANA 125 and 129 seeds because their dose rate is so high that the patients are not allowed to leave the hospital. And just from a regulatory perspective, that used to be a European specialty, but now it's cesium 131 that is being implanted similar to the prostate implants. And I think we should keep an eye on this because there's some other new technologies coming for partial resections. The gamma tile, which is one of these implantable wafers that creates local radiation to the resection cavity, has been advocated for gliomas and metastases. I think the dosimetry is very hard to understand because you have an irregular volume and hence you don't know whether you really penetrate, and when your volume of the resection cavity collapses, your dosimetry becomes fairly unclear to me, to be kind. But there is technology out there that we should watch.
I fully agree with you. I believe that we really should keep an eye on that because also this is there is some surgery which will remain with us, you know, unlike with cyber or gamma knives where there is no open surgery at all. So I fully agree that it's very nice technique, but as I recall, Ton was dealing with that for many, many years. You know, the first lecture by him I have heard sometime in 80s or early 90s.
So the big argument that I want to put forward why we should not sign up for stereotactic radiosurgery for gliomas, there is we don't have a tissue diagnosis and we lose our molecular markers. And if you do a stereotactic biopsy, you can use the same pathway to put in a laser interstitial therapy device, and you can create local thermoablation, which can now be done with a side-firing probe, and that's an asymmetrical tool to deliver high-dose thermocoagulation, in this case, to tumors. And I think for pilocytics, that may work really well as well, just as a final comment.
Definitely, fully agree.
Okay,
let's go ahead. Do we have Paolo Kadri with us? If not, Abida, it's up to you. Are you at home already?
No, I'm home.
Okay, so please, Abida, we are very glad to have you with us. And as usual, we are to expect some white matter anatomy, which is always excellent from you. So go ahead, please.
Thank you, Dr. Banesh. And today I'm going to be discussing the anatomy of the limbic system and some approaches for limbic paralimbic tumors. So if we see the limbic system is, you can see my screen, right?
Yes, everything's all right.
Okay. So the limbic system is basically on the medial aspect of the hemisphere. And if you look at this image, it forms a series of Cs around the hemisphere. So we'll discuss all these series of Cs that are there. So there are some structures that go above the corpus callosum. There are some structures that go below the corpus callosum. And the whole anatomy revolves around this choroidal fissure. And that is the limbic system that we're going to look into today. So if you see this whole thing, the limbic system is not just the Papez circuit. There are many other circuits that are along with the Papez circuit. So there are a lot of, there is one circuit that goes above from the corpus callosum, from the hippocampus going all the way above the corpus callosum, and that is the supracallosal circuit. Then you have two circuits that come from the amygdala. So that is the ventral amygdalofugal pathway, and one circuit that comes from the amygdala going up into a C like that, and that is the dorsal amygdalofugal pathway. And then, of course, there is the Papez circuit. So let's look into all these circuits one by one. So basically, to understand the limbic system, you have to understand how evolution occurred. So when the amphibian left the oceans, they developed a sense of smell. They developed a long olfactory system, which helped them to find the danger source by the sense of smell. When we became mammals, there were two structures that formed, the amygdala and the hippocampus laterally, and the olfactory or the piriform cortex medially. And these are the basic limbic structures. These structures are the primitive cortex, that is, they're consisting of 3 layers of allocortex. Around this medial cortical ring developed paralimbic structures, that is the insula, the parahippocampal gyrus, the cingulate gyrus. So they formed a ring around these primitive mesial structures. And around that, you had the neocortex, or the 6 organized layers of the parainsular structures and the neocortex. So the limbic system is actually the least understood part of the nervous system. Why limbic? Limbus means border or margin, and it is at the margin of the middle aspect of the hemisphere. So it was first referred to as limbus by Thomas Willis. Then Paul Broca called it Le Grand Lobe limbic. Then when MacLean did some silver studies, he saw that there were cortical, subcortical, and fiber connections, and he called this whole system the limbic system. And then Nota, in further study, extended the limits of the limbic system to the brainstem. So Pape's circuit is the most important component of the limbic system. So Pape's postulated that the anatomical basis of emotion was found in the hypothalamus, anterior thalamic nuclei, cingulate gyrus, the hippocampus, and all its connections. So we did this study on the Pape's circuit quite some years back, and I'm going to present the findings. So as you know, we use the Klinger's technique to do the dissections. And these are the various components of the limbic system. So the gray matter part of it is the hippocampal formation, the amygdala, the hypothalamus, the nucleus accumbens, the cingulate cortex, areas of prefrontal cortex, and nuclei of midbrain. The white matter components of it are the cingulum, the medial and lateral striae, the fornix, the anterior commissure, the mammillothalamic and mammillategmental tracts, the stria terminalis, which forms the dorsal amygdalofugal pathway, the dorsal longitudinal fasciculus, and the medial forebrain bundle. So these are the main structures around which the limbic system revolves. So if you see, this is a superior view of both the hippocampi and the fornix going to form the mammillary body, and they curve around and form a C here. This area between both the hippocampi is the region of the hippocampal commissure. So this is how the hippocampus lies on the in the medial surface base of the temporal horn. So these fibers that are forming on top of the hippocampus are fibers of the fimbria, and they go on to become the fornix. In this region here, in the roof of the temporal horn, lies the amygdala. As you can see in this image, this is the cut section of the hemisphere, where you see this is the temporal horn, this is the hippocampus, and this is the amygdaloid nucleus. So this is a very important relation that is important in mesial temporal lobe surgery. So let's look at the structures from an inferior aspect and then from a medial aspect. So when you look at the inferior aspect of the brain, this is the brainstem, of course. So this region here is that of the uncus. Now the uncus has two components. The anterior part of the uncus actually harbors the amygdaloid nucleus, and the posterior part of the uncus harbors the hippocampus. And then more posteriorly, it goes on to form the parahippocampal gyrus. So these are the structures. Here you can see them more clearly. This is the part of the hippocampus, and this is the part of the amygdaloid nucleus. And as they are going backwards to form the parahippocampal gyrus. So once you remove the fibers, now once you do fiber dissection on the inferior aspect, first fiber that you will see here are these transverse longitudinal fibers that are coming from superiorly and going towards the temporal horn. These are fibers of the termination of the cingulum, and they're known as the radiation of the cingulum. Once you peel off these fibers, you start seeing a bluish structure, and that is the ependyma of the temporal horn. Once you peel off the ependyma, this is the whole beautiful hippocampus. So this is the head, the body, and the tail. This is the choroid plexus in the temporal horn. And here in the roof of the temporal horn is the amygdala. So this is the relation. So this, as I told you, this is the uncus. So the anterior part of the uncus harbors the amygdala, and the posterior part of the uncus harbors the head of the hippocampus. Now, what happens if I deflect the hippocampus and the choroid plexus? I start seeing fibers that are coming here from the region of the lateral geniculate body, and they go upwards towards the roof and lateral wall of the temporal horn. And these are fibers of the Mayer's loop. When you see them from this side, here you can see them quite clearly. I've turned the specimen. And then when you look at it from the lateral aspect, here you see that these are the fibers that curve and to go and then join the optic radiation. So this relation is again important when you're approaching the temporal horn from the lateral aspect, and you have to avoid damaging these fibers so that you do not have a visual deficit. So we've looked at the structures from the inferior aspect. Now let's look at the Pappage circuit from the medial aspect. Before that, there is one more circuit that we have to know. So this is the medial aspect of the hemisphere. This is, of course, the corpus callosum that you're all familiar with. Now, on top of the corpus callosum, there is a thin layer of gray matter that runs, and this is the inducium graecium. So the inducium graecium is actually a continuation of the dentate gyrus, which becomes the subsplenial gyrus and then runs above here. It harbors two striae within it. So if you see these white bundles here that are running longitudinally, these are the medial and the lateral longitudinal striae. So these structures that come from the hippocampus go all over the corpus callosum and end in the subcallosal area is the first circuit of the limbic system, and that is the supracallosal circuit. So that is the circuit number one. Then let's go on to the Pappage circuit. So this is the medial aspect of the hemisphere. So this is the hippocampus. This is the parahippocampal gyrus. So where the parahippocampal gyrus turns, you have the edge, that is the subiculum, and then around it again the hippocampus turns, and that's how they are all related on the medial aspect of the hemisphere. Now you start dissecting in this region. So above the corpus callosum, the first fiber bundle that you see here is the fibers of the cingulum. As I told you, they end in the region of the hippocampus here. So you start seeing these bundles that are going above, going all the way into the region of the entorhinal area, parahippocampal region. And this part is the radiation of the cingulum. So now here you can see them dissected more beautifully. This is the subcallosal region where it begins, goes over the hippocampus, and then turns there to end in the entorhinal area as radiation of the cingulum. Now note that the cingulum has two very prominent connections. This is the connection of the cingulum to the precuneus, and there is one connection to the superior frontal gyrus. So this is how the limbic system or the Pappage circuit communicates with the neocortex. Now coming back to the limbic system, so this is the fornix, this is the choroid fissure, and this is the region of the thalamus. Now if I dissect in this region of the thalamus, the first structure that I see here coming from the mammillary body is the mammillothalamic tract, which goes on into the anterior nucleus of the thalamus. This, of course, is the fornix, the columns of the fornix, which come here to the mammillary body. If you see, there is one more tract that is going down here, right up to the brainstem, and that is the mammilotegmental tract. Going further, here you can see this gray matter of the anterior nucleus of the thalamus. Then here, the cingulum that is ending here, just a refresher, the fibers of the cingulum. So this portion of the cingulum is the isthmus of the cingulum, and it goes down here and ends here near the hippocampus, and that is the radiation of the cingulum. So now you can see all these structures. Now, as I said, when you dissect more, you see this denticulate structure here, that is the dentate gyrus. So when you turn across from here medially, laterally, you will see the dentate gyrus, which goes on above the corpus callosum. And I showed you earlier, it forms the subsplenial gyrus and then continues as the inducium graecium and ends in the subcallosal region. So now I have removed the dentate gyrus and you see the fornix. So this is the fimbria and this is the fornix, the columns of the fornix, the mammillary body, mammillothalamic tract, the anterior nucleus of thalamus. Now coming to the last portion of the Pappage circuit, I have cut the corpus callosum here, and this structure that you see in the base of the ventricle is the caudate head. When I lift the caudate head, I see fibers that are running here from the anterior nucleus of the thalamus and going on to connect to the cingulum. These are the anterior thalamic radiations or the anterior thalamic peduncle, and it goes on to form the cingulum. So now you can see that all the fibers I've dissected here, these are the thalamic radiations, the anterior, the superior, the posterior, and the inferior thalamic radiations, and how they go on to enter the brainstem. And this is the whole Pappage circuit that has been dissected. So now you see it completely here. So the fornix, the mammillary body, the mammillothalamic tract, the anterior nucleus of thalamus, the anterior thalamic nucleus radiation as they connect to the cingulum and come down here to end again in the region of the hippocampus, thus completing the circuit. Then we just dissected the whole circuit out of the hemisphere, and this is the complete limbic system, which I showed you. This portion is the olfactory tract with the medial and lateral olfactory striae, and this is how they also connect with the limbic system. So this one through the amygdala and this one through the subcallosal region. So going further, how does this anatomy apply to resection of tumors? So this is a recent paper on the white fibers of the brain, and this is a recent strategy on en masse surgical resection for short arcuate fibers. So this is how we've divided white fibers of the brain. I'm not going to go into these details, but now I will show you how this applies to surgical approaches. So this is a medial temporal tumor. This is actually in the region of the parahippocampus. This is exactly where it lies. How can we approach this tumor? So approaches to the mesial temporal region, there are multiple approaches. So there is a approach that is described by Professor Yasser Gill, that is the trans-Sylvian, which he modified later to go on through the region here. Then you have the lateral approach to the middle temporal gyrus, the inferior approach to the inferior temporal gyrus, and then the posterior approach from supracerebellar going right up to the mesial temporal region. And this is the anatomy that is important while using this approach. So this is what you have to remove, the amygdala and the hippocampus. And this is where you do not have to go further, because if you go ahead with this margin, you will straight enter into the globus pallidus and the basal ganglia. So this becomes your limit of resection. So I'm just going to show you quickly the anatomy through the lateral approach. So this is the lateral aspect of the hemisphere. These are fibers when you dissect. This is the insula. This is the SLF 2 and 3. This is the arcuate fasciculus, the middle longitudinal fasciculus, ILF. So when you're going to the temporal horn, you're actually entering into this region. So this is the uncinate, this is the IFOF, this is the ILF, and this is of course the arcuate. So when you enter from this region, you're hardly going to cause any damage to the white fibers. The ones that you have to avoid is this IFOF and the optic radiations. So this is the point that you enter, and this approach has been described by Professor Goel, and we have been using it consistently for our amygdala hippocampectomy and for our mesial temporal tumor resection. So if you see this orange circle here, there is a region in the anterior aspect of the temporal horn where there are no fibers. So this is the IFOF and the optic radiations. So here they lie in the roof, and here they lie in the lateral part of the temporal horn. So if you enter from this region and carry out your resection remaining just beneath the roof of the temporal horn, you will avoid causing any visual deficit. So this is, see, again, you can see the relation. This is the hippocampus. This is the optic radiation. So you enter from this region and remain beneath this roof, and you will not cause a visual deficit. And this is a recent white fiber correlation of amygdala hippocampectomy using this approach that we have been using, as has been described by Dr. Goel. So again, coming back to this tumor, so you see this medial temporal, we have come laterally, gone in and resected the tumor completely. This is again another parahippocampal tumor. This is a tractographic image to show that all the fibers are actually displaced superiorly. So this becomes a very safe entry to come into this through the middle temporal gyrus and do a complete resection of this parahippocampal tumor. Again, a tumor in the posterior aspect of the parahippocampal gyrus where it joins the cingulate. Again, entered using this approach. See all these fibers here. See the tumor is right beneath it. The only fiber bundle that might be a little bit in jeopardy is the ILF, but a unilateral damage to the ILF is generally well tolerated. Again, another tumor in the region of the parahippocampal gyrus, and it has been removed using this trajectory. You can see it very nicely. This is the middle temporal gyrus approach to the mesial temporal structures. Now coming, as we have divided our tumors, so a tumor arising from the region of the cingulum will be a diffuse glioma. So if you see this image, this is the cingulum. You see the tumor is extending along the connection of the cingulum to the neocortex, and this is a completely singular tumor. If you understand the white fiber anatomy, use this blue structure here, that is the vertical fibers or the projection fibers, are the vertical limit, and your tumor will never cross that boundary when it is coming from the cingulum. So the best approach for this is interhemispheric. You go in and remove the tumor completely without causing any deficit to the patient. Again, another tumor in the region of the isthmus of the cingulum. So this is where the tumor lies, and the best approach for this is using an interhemispheric approach. You have used neuronavigation in this, and this is the trajectory, and you can see a complete excision of the tumor. Again, another singular tumor that has been removed by the interhemispheric approach. So these are all limbic and paralimbic tumors. Now, this is another interesting approach that was described first for a mesial temporal epidermoid tumor by, again, Dr. Goel. So we use the lateral supracerebellar approach. So this approach is now being used by some centers for a mesial temporal surgery, lobe surgery, but we had used this for a tumor on the middle fossa using the lateral supracerebellar approach. This is again another epidermoid that we have recently done. I don't think I will have time to show the image. or a video, but this is the anatomy of the approach. And it is one of our favorite approaches, the lateral supracerebellar approach. If I have time, we can see the video later, but I'll just show you a bit of it, just to show you how the tentorium is incised here. So this is the supracerebellar. The tent is being incised here, protecting the fourth nerve, and then working above the tent in the region of the mesial temporal region, in the suprasellar cistern, going all the way and excising the epidermoid tumor. And this is at the end of resection where you see the suprasellar structures quite well. So again, this is where is this tumor? Now, this is another part of the limbic system. This tumor is in the choroid fissure. As you see, the choroid fissure opens here into the ambient cistern. So again, approach to this tumor is through the lateral aspect, below the roof of the temporal horn. And this is an intraoperative image after I've removed the tumor, and this patient did well. Lastly, coming to the choroid fissure, this is a very important anatomical structure to understand. As you see, it is a C-shaped structure. If you enter the choroid fissure from this region, you will straight enter into the quadrigeminal cistern. If you enter it from this region, you will enter the ambient cistern. So the choroid fissure forms a point of entry into the basal cisterns, and that is a very interesting anatomical landmark for us to get oriented with the cisternal anatomy. So this is how the choroidal fissure runs. This is hippocampus and the fornix, and this is the region of the thalamus, and this is the whole C-shaped choroid fissure. And if you realize, the whole limbic structures are organized around the choroidal fissure. The last 2-3 few structures of the limbic system that we should not miss is on the base of the brain. So this is the olfactory tract. This is the lateral olfactory striae, medial olfactory striae. And if you dissect in this region, this is the anterior perforated substance. So if you dissect here, you will come into the substantia innominata here. And these fibers that you see here are fibers of the anterior commissure, which also form part of the limbic system. This is the whole anterior commissure dissected. This is the frontal component. This is the temporal component. And when you see it from laterally, turn the image. So these are fibers of the IFOF and the optic radiation. Also, the anterior commissure fibers join this sagittal stratum as they go laterally. And as I like to say, this anterior commissure actually hugs the temporal horn on both the sides. If you see the temporal extension, it goes all the way and runs all the way into the sagittal stratum and actually hugs the whole hemisphere. So coming back to the limbic circuits, so we saw the supracallosal circuit, the Papez circuit. Then there is a circuit through the stria terminalis. So where does this circuit come? It comes from the amygdala. It runs in the groove between the caudate and the thalamus and ends in the subcallosal region here. So these are the 3 vertical circuits. And then you have one basal circuit, that is the ventral amygdalofugal pathway, that goes on from the amygdala on the base of the brain to end in the subcallosal region. And the limbic connections to the telencephalon, diencephalon, and mesencephalon are the stria medullaris, the fasciculus retroflexus, and the medial forebrain bundle. So if you see here, this is the region of the habenular, this is the pineal body, and this is the stria medullaris thalami. And posteriorly, these are important commissures that we should not miss. So in the superior leaf of the pineal is the habenular commissure, and in the inferior leaf is the posterior commissure, as you can see here. So this is the habenular commissure, and this is the posterior commissure. So these are all structures of the limbic system, and I've tried to show you the whole anatomy of the limbic system. I hope you have enjoyed. I'll be happy to take any questions. Thank you very much.
Thank you very much. That was great. These dissections are extraordinary. I liked when you said that when we became mammals. That's nice. We were insignificant East African ape for 2 million years, and now we still have the same limbic system on which we operate even now with nuclear weapons and all that. And any questions for this?
I have a question.
Heck.
So when you have an epidermoid that sits paracellar, mesial to the temporal lobe on the left side and reaches inferior to the clivus, it's very hard if you come in from posterior, the way you had described the supracerebellar transtentorial approach, because I don't know how you reach around the corner. So in these cases, you know, you showed your left, you showed on the right side a transtemporal approach through the middle temporal fossa. Do you think on the right side you stay transtemporal, and on the left side you would do an OZ?
No, so the approach on the right side, so it depended on the location of the epidermoid. If the one that I showed you on the right, I showed you two epidermoids in the paracellar region and one in the choroidal fissure.
Yeah.
So the one in the choroidal fissure, I went through the lateral side, through the temporal horn.
Exactly.
The one was completely mesial temporal and coming a little bit down next to the brainstem in the ambient cistern. That one went supracerebellar. So not the ones that are going all the way down, but even the ones that you go down, if you finish your supracerebellar resection, then you can always come in from the CP angle because you already have the exposure and then get to that part also.
Okay.
One more question to that. Did I see properly that you do not open the tentorium as far as the tentorial edge, that you leave, you just make a cut and you leave the...
No, it depends. This one had a flap-like thing that was raised.
Right.
And it didn't go all the way to the edge. Just to keep the fourth nerve okay. But otherwise, yeah, you can go all the way, dissect the fourth nerve on the lateral, on the cerebral peduncle, and then cut the tentorial edge. That is just an individual variation.
So it's individual decision. It's not.
Yes.
Okay. You know.
Yeah, we have 1 second. I want to just flash up a scan if I can. Can you see my screen?
Yes.
Yes, we do.
So this is the tumor I was just talking about. Just pulled it up by chance, and I hope I can briefly show this because it's hard for me to drag this image. But you see the tumor sits supracellar and then left-sided mesial temporal, and then reaches all the way down the clivus, right?
Yeah.
So to get to this lesion from posterior, you cannot go supracerebellar because you can't reach around the corner. But I was wondering, you know, an epidermoid is such a benign tumor. You don't want to do an OZ to get there and then have your problem from the access, right? So does anyone have a good idea how to tackle this one?
Why not resecting just the supratentorial part and leave the other behind for the further growth for the second procedure?
Well, I was thinking about one could also do one part retrosig, come up and clean out what's in front of the clivus, right? And do the other part coming from the front, like subfrontal, and reach paracellar mesial left side, because I don't want to,
No,
these
are basically, this is the tentorial edge. Your tumor is going above it and your tumor is going below it, right? So these are, we call them CP angle tumors, but I think if you read Professor Goel's paper, he's described this way back. He calls them tentorial epidermoids. So what you do is you approach it in 3 stages. You go suboccipital, retrosig, okay? You first go above the cerebellum, resect the part that is here. If you want, you can go above the tent and remove that. Then after you finish that resection, just retract the cerebellum laterally. You already have the space and you will be able to get the part that is in front of the brainstem. That's how we do it. Even in huge epidermoids, that's how we do it.
Yeah. Maybe I send you the pictures and we can rediscuss. I only had the CAT scan there in my email, so I didn't. But thank you. Awesome presentation. I loved it.
Thank you.
Okay, anyone else? Abira, thanks. And we now have the last lecture of the first session. It's Professor Stefan Florean from Cluj in Romania, and you will talk on fourth ventricle tumors. Stefan, please.
Thank you very much. I really enjoyed the previous presentation. Yes, great anatomy with real applications in the practice. Thank you very much. So I will talk a little bit about some controversial issues in the fourth ventricle tumors. And certainly there is a very well known anatomy. It's the fourth ventricle anatomy. It's quite well described by Roton and many others. And generally speaking, it's an turnover tentry, middle line structure that has a floor formed by the pons and medulla, and there are some very known landmarks: stria medullaris, median sulcus, sulcus limitans, median eminence. And I will not enter into details, anatomical details. They were, I'm not able to present them as Avinda already presented. The roof is formed partially by superior cerebellar peduncles, superior medullary velum, and the lingula, and the roof in the of the inferior part of the roof is formed by inferior medullary velum, telechoroidea, choroidal plexus, and uvula, and the nodule. So these are, generally speaking, the structures into the fourth ventricle. And to reach the fourth ventricle inside, we have two main routes. One is transvermian, and the other one is opening all the fissures, the so-called telovelar approaches. And these approaches were quite well described recently in the literature by Professor Roten, and the anatomy is very well known. I will not insist on. But what are the most controversial issues? First of all, we have the symptomatology. It's unclear. Generally, there is no pathognomonic sign for the tumors located in the fourth ventricle, except those with increased intracranial pressure due to the hydrocephalus. So, especially in small and at the pediatric age, and especially in small children, it's quite difficult to diagnose based on the clinical symptoms if there is posterior fossa. Usually there are non-specific signs, irritability or lethargy, vomiting, anorexia. The most frequent symptoms under the 3 years of age are macrocrania, nausea and vomiting, and irritability. These are, and especially irritability, should conduct us to think about something in the posterior fossa or in the fourth ventricle. And for children and adults, headache, nausea and vomiting, dizziness and coordination disturbances are later onset symptomatology. But when I started neurosurgery, the ophthalmoscopic examination was the rule, and many pediatric neurologists tend to exclude, and also ophthalmologists to exclude, the posterior fossa or intracranial tumor in patients without papilledema. Now we know that in children under 80 years of age, only 13% are presenting papilledema, and only 10% of the child under the 4 years. So it's nowadays inconclusive examination in order to exclude at least posterior fossa tumor especially. And this is a case, an illustrative case. 2 years and 7 months old boy, and with a history of 2 years doctor's delay. The mother went to the doctors and they applied all kinds of treatments to this child until they perform the CT and then an MRI. After 2 years of different treatments applied for this child. When he was admitted, he was almost in coma. We operated in emergency and we completely removed the tumor, but the patient remained blind despite all the improvement, neurological improvement. So the diagnosis of posterior fossa, and especially the fourth ventricle tumors, are essentially imagistic. That's why, as soon as possible, when you have a suspicion of something that it's growing in the posterior fossa, perform an immediate MRI, preferably in emergency, CT, contrasted CT, but for the surgery, MRI, contrasted MRI, it's mandatory in order to have all the data related to the pathology. I'm explaining this, and maybe you are in the same situation when the neurologists are so hesitant, and especially the pediatric neurologists are so hesitant to indicate an MRI because a small child should be anesthesiated for an MRI. There is no contraindication for MRI in children. So what we should do with these tumors in the fourth ventricle, surgery is the main step. The extent of the tumor removal, it's directly related to the patient's outcome. And knowing that for the children's radiotherapy under 3 years of age, radiotherapy, it's not applicable. And in some cases, even chemotherapy, especially for ependymoma, it's not relevant. Surgery remain for many of these kind of tumors the main tool in order to solve the problem. And for the benign tumor, like those presented by Professor Benesch, pilocytic astrocytoma, if you completely remove the tumor, the patient is cured. So most of these tumors are presenting, as I mentioned, with symptoms of increased intracranial pressure due to the obstructive hydrocephalus. How to manage this? So we have many tools. So we have some major tools in order to solve this one. Usually, when you completely remove the tumor, the hydrocephalus is solved, and even if the dimensions of the ventricles remain large, we still have a ventriculomegaly. We do not perform ventriculoperitoneal shunt unless it's symptomatic. Otherwise, I do not treat the ventriculomegaly. I only treat hydroactive symptomatic hydrocephalus. And for the treatment of hydrocephalus, preoperatively, we can perform an endoscopic third ventriculostomy, which is highly effective. But operating in posterior fossa and having, especially in sitting position like we are using to perform this kind of operation, we can perform an external ventricular drainage on the side just before dural opening and posterior fossa. It's an increased, it's a kind of a risk for upward central herniation, but until now I didn't encounter this kind of complication. And certainly, as I mentioned, for the patient with persistent active hydrocephalus, symptomatic hydrocephalus, we are performing ventriculoperitoneal shunts. So we still have another options if we are not sure that we completely remove the tumor and obstruct, especially the upper part of the ventricle, the Sylvian aqueduct. We can perform a kind of Torkelson operation. In fact, we introduced this catheter into the posterior part of the third ventricle, and then the contralateral part of we are introducing in the cisterna magna, where it is anchored with some wires, and in that manner we can keep the permeability of the circuit below the tentorium, above the cerebellum. It's you know, the Torkelson operation, it's outside the skull. This kind of operation we published 5 years ago. It's effective in selected cases. So another controversial issues related to the position of the patient. The prone position is the most widely used, and it presents a lot of advantages, and certainly it's comfortable for the surgeon. It has the disadvantages that a flexion of the neck may occlude the endotracheal tube, and the tube may become endobronchial. For my point of view, if you stay in front of the patient, all the anatomy, it's completely upside down. So all the reports, as I am used to look to the operations, are completely reversed. And considering that tumors in the fourth ventricle are deeply located, you should permanently have an aspiration in order to maintain the vision in the most deepest site of the operating field. Another variation of the prone introduced by Kobayashi, we know the Concorde, it has advantages and the same disadvantages like prone position, and it has also some specific complication like necrosis of the chain and obstruction of the cerebellar venous outflow. I'm not very pleased with this Concorde position, but instead of prone position, I rather prefer to operate when the sitting position, which we have introduced in 1975 in our institution, and since then the immense majority of the posterior fossa lesions and also upper cervical or craniovertebral junction lesions, we are operating in sitting position. And for me, it has a lot of advantages. We have all the normal anatomical reports. What it's up, what it's down, The gravity, it's the best assistant of neurosurgeon. Increase the supracerebellar, especially in pineal region tumors. We reduce only a little bit the retraction of the cerebellum. We have always a clean operating field because of the drainage of the blood and the CSF, and usually there is a reduced blood loss comparing with other position. And for neurophysiological point of view, you have a good access to the patient face, so you can monitorize every cranial nerve. So the major disadvantages and the scary movie of this position is the air embolism. I have to mention that in every single case, there is a small amount of air embolism. But if you work with your anesthesiologist in a team, you can manage every single case. I only had 2 major complications in which I was forced to put the patient in a prone position during the surgery, but in thousands of operation I performed in sitting position, there were only 2 cases I remember now. So there is an hemodynamic instability. So for the older patients and those with cardiac problems, I do not recommend. And the upper extremity fatigue of the surgeon, you can solve this with a special chair with support for the arms, so it's not a problem. But for the patient, the most frequent complaints are headache due to the postoperative pneumocephalus. Only in extremely rare cases there is a tension pneumocephalus that needs an opening. So for approaching the fourth ventricle tumors, we are using the midline suboccipital approach. In the last 15 years, largely we used the craniotomy instead of craniectomy, and in children with descending of amygdala, I rather prefer not to completely remove the C1 if it's not necessary. I reduce only the superior half of the C1, and in that manner, having 2 or 3 millimeters in addition, it's usually enough in order to decompress the amygdala. The dural opening usually we perform in Y or V shape with ligation of the midline sinus. But in the last 5 years, I largely used also a C-shaped unilateral midline based opening, especially if the tumor in the fourth ventricle or in its midline but lateralized somehow. So another discussion is how to enter the fourth ventricle, to split the vermis or not. There are discussion because some authors are against splitting the vermis because of the complication, especially the cerebellar mutism, and some are arguing that this complication was only seen in children who had the vermian split that included the entire inferior portion of the vermis. Others have arguments that demonstrate that both superior and inferior vermian incision have been associated with postoperative mutism. And on the contrary, some experienced authors mentioned that the majority of the children with posterior fossa tumors undergo radical resection through the vermis and do not develop cerebellar mutism. And if vermis is responsible for this complication, it could appear immediately and could be more persistent. And there is a delay on the onset of the cerebellar mutism, and also it's a negative clue. This is a negative clue of the role of the vermis. So still there is debate. So transvermian approach I use only when this part of the vermis is involved in the tumor, and I do not open more than 2 centimeters from the inferior part of the vermis in order to have enough space to completely remove the tumor and to avoid rupture of the vermis during the surgery. So what I consider that it's very important, it's not to excessive retract the vermis. And here it's an case in which we remove, we dissect the part. I should end or
in a minute.
In a minute. Okay, so this is a case in which we split the vermis and we completely remove the tumor. We have also the some cases in which tumors destroyed completely the vermis, and telovelar approach, it's, as I used in the last 10-15 years, the most frequent approach, and this was could be combined in very large tumors like this one with a supracerebellar for the upper portion of the tumor, and then you can move to the inferior part and remove to a telovelar. In fact, telovelar approach means that you should dissect all the adherences in order to enlarge the spaces, the natural. You are using a natural route to reach the fourth ventricle. So you can enlarge these spaces as much as you need, and then you can remove the tumor, like in this exophytic tumor of the fourth ventricle flow. I will not insist on that, and I will go directly to the conclusion because I don't have time. I have some examples of medulloblastomas, ependymomas, and pilocytic astrocytoma, which are usually exophytic tumors, cyst-like tumors. This was an epidermoid in the fourth ventricle. As a complication, some are related to the position. Leakage of the CSF, it's a common complication in posterior fossa, up to 50%, but only 1% will present meningitis. Significant headaches and distant supratentorial hemorrhage without a well-known understanding. And I will not insist on cerebellar mutism that can be encountered even in you are performing a telovelar approach. The risk factors are brainstem involvement and midline location, large volume, medulloblastoma, especially 24% of the cases, and the pre-existence of preoperative language impairment. So in conclusion, fourth ventricle tumors are challenging. Clinical manifestations are not specific. Native CT usually it's irrelevant, so that's why we need a contrasted imagistic. And these are rare tumors, so surgical experience it's lacking. Usually, when you open a tent, like fourth ventricle, you are using the zipper, so telovelar approach. Do so when you open the fourth ventricle, use the natural ways. And at the end, in the last 500 years, nothing has changed. You see there this picture, very well known. Sitting position was used then, like it is now. The awake surgery was used then, like it is now. Neurologists, which are full of science, are amazed how many things can a neurosurgeon do. Thank you for your attention.
Ivan, thank you very much. The last image is perfect. It's really sitting position. Never realized that, but all these images from the past are in sitting position actually. All right, we have time for one or two short remarks. Yeah. I just wonder that the retraction when through teloveral approach in sitting position, how do you keep the tonsils up?
We are using a dynamic retraction. I don't use fixed retraction. So I always operate with one or two assistants which are trained in this. And I use, with one hand, I use the aspirator or the bipolar, and the other one, the assistant is keeping the vermis or the amygdala.
I see. So that is why you call it dynamic retraction. Is the
yes, because they are moving
the
along.
spatula.
Yes, along with my progression. So it's a dynamic retraction. It's not a constant, not a fixed position.
Okay. Thank you. Professor Kanan has joined us.
Well,
Imat, do you want to say
yes,
something?
I am really sorry. I arrived late this morning from Turkey, and I'll just catch up with you. And thanks all of you for being there and specifically to Vladimir taking the session leadership on the subjects. And thanks all the speakers. Please proceed
Very
with
good.
this if you want.
Very good. Thank you, Imad. We now go to the second part of the webinar, and I shall hand over the moderation to Ek Kasper and Ramesh Nair. Ek is with us, Ramesh?
Yeah, yeah.
Yeah, good.
Thank you.
All right,
Thank
the floor is yours, guys.
Yeah,
Thank you.
thanks, Vlad.
Ramesh, you start?
Yeah, I think if you would like to start, Ek, I'll start with the next one then.
Okay, so it's my pleasure to welcome Hyperion for the first talk of our session. Here, he wants to give us an overview of robotic endoscopic holder and other new advances for intraventricular tumor surgery. Hype has always been an innovative disruptor, so I'm eager to hear what you have to say. You're muted, Hype.
Mute.
Well, good to see all of you. Long time. Last time we saw was in the IANA after a long COVID hibernation. So, you know, it's good to come back to India, settle down here. And, you know, I see Henry here. In less than 10 days, maybe in 10 days, me, Henry, and Willie Coolwell, we are going to the highest motorable road in the world. So we are going to spend 10 days together. And I hope, you know, we have some good time. So I'll share my screen. I wanted to show you a few things. Can you see my screen?
Yes.
Yeah.
Yeah, so about 6 years back, we felt the need that just like a microscope, we also need the endoscope to be steady in the field. So, well, it's as Stefan said, a dynamic retractor with a trained assistant holding. We used to have our assistants holding the scopes, but then for TNTs as well as for intraventricular surgery, sometimes this is not very desirable, you know. One thing is you cannot have a floating assistant. The guy is always in your field. That is one thing. Second thing, you're lucky if you get an assistant very lean and thin, and sometimes the assistant can be huge and you'll be working around him. So, I mean, the assistant is holding your scope, but there are many problems if the assistant doesn't really understand you, especially in ventricular surgery. Believe me, I prefer to hold the scope. If I'm holding it, I prefer to hold the scope rather than the assistant holding the scope, because the margins of error is very little. So we went for this pneumatic set around. I'm sure Henry and many of you would have used this. So we used this for 4 years, and it was quite okay. But when it came to operating with a microscope and this, it was not practical. So I will show you, for example, see, this is a microscope, and then we have the endoscopic holding pneumatic arm here. It was not very practical. So we wanted to think about a new option. And plus the pneumatic arm was in such a way that, you know, the moment you push the switch, it will collapse like a young girl into your arms. And it is really dangerous when you are in the ventricle or when you are near a critical structure. It's really dangerous, you know. So you don't want to be having that. So we thought about different things, and then we came up with this robot, which is, can you see this, guys? Can you see this?
Yeah.
Yeah, so this is an industrial robot. It's a German origin robot. It's a Franca Amica. So what we thought is we got it to Karad, and then we started programming it. And then we figured that, you know, this is very safe. In fact, it has force sensors, and if it the advertisement is such that even if it touches a balloon with a needle before the balloon bursts, it is extremely safe, and it is back drivable, which means it has anti-gravity motors, so you can literally take it all around, completely floating, just like the microscope.
The video is not running. This is the video?
I will show you the video. So you can see now. Yeah, so you can see how with just is my friend Charlie who came to see this, and you see how we are operating now with the scope. So Escolab designed the NeuroPilot and the attachment to the scope, and now I can use the scope and I can make with the NeuroPilot I can make movements in all 3 planes, and I can operate along with the exoscope. I mean, just by the side of the exoscope you can see. So this is the NeuroPilot. This is the NeuroPilot, and the scope goes into the NeuroPilot, and the hand, the robotic hand, is holding it, and I can make minor adjustments X, Y, Z easily with the NeuroPilot. Now we are thinking about completely taking off the NeuroPilot and making it intuitive again, so that the scope, along with the scope, this moves. Instead of the NeuroPilot attachment, we're trying to take it off completely. So this is how it works. So you can see on the exoscope image on one side and the endoscope image on one side. And with this, the endoscope that can assist your cranial surgery can even be the Einstein Vision, which is actually a 10mm scope, which can go into the field from a completely different perspective from your exoscope. And the Einstein Vision is 3D vision. It's excellent 4K 3D vision, and it is really useful when you have this scope holding. And this is how it works. We programmed it with an Indian company, Asimo Robotics. So you see the attachments. This is 3D printed, and this is the NeuroPilot, and this is holding the scope, and that's the camera of the scope. And so we use it for interventricular surgery, transnasal surgery, and as an adjunct to the, so we are here using it for an aqueductoplasty. So this is a 1-year-old infant with tuberculosis. So ETV is impossible here. So we found the web, and then we went, perforated it, and now we are looking at it, posterior commission. You can see it going. So, and you know, you can go in, inflate the balloon, and then go into the 4th ventricle through the aqueduct using a pediatric scope. And you are into the 4th ventricle now. You can see the choroid plexus of the 4th ventricle going and dilate. Instead of the ETV, we can do this aqueductoplasty. So the thing is, when you have something which is holding the scope for you, now we are using the 3D vision and practice simulation. So for anastomosis, we are using it both with the exoscope and the endoscope. I'm sorry for the very bright picture here. So both, one is the endoscope and one is the exoscope. One is the 3D endoscope. Here we are using it for a transclavial brainstem lesion. So that is the endoscope holder, and it is the standard 4mm scope, and we are using it. And as we were showing, it's a 7 DOI robotic arm. So you have 7 degrees of freedom. So it's just brilliant. So you can adjust it in whatever way you want, and it gives you. I would say it is the next step. So I'm sure things like that would start coming into the market soon. I'm sorry that right now we are looking with Escolab to get it as a robotic exoscope holder, but I'm very sure very soon it will be in the market soon. And this, my friends, when you come to India for the next meeting, this is where the home is. Instead of Nepal, we have settled in India, and this is the jungle all around. It's a Sahyadri Wildlife Reserve with tigers. Every time we go to trekking, we see the tiger paws the tiger's footmarks, and this is the home. So the next time you guys come, I remember all of you guys came to Nepal, we could host you, but now this thing is taking shape, and this is where I will stay. So next time you guys are in India, I would be very much happy instead of Nepal. I mean, I think this would be far better because this is really the wildlife reserve all around us. Thank you very much. I'm sure I have enough time for questions and discussion. So please, guys.
Can I ask a brief question about who manipulates the robot during the case? In your initial part of the video clip, the robot wasn't even draped in. So it needs to be a second person next to you who is in control of the robot.
Yeah, so we started, for the last 20 years, we don't drape our microscopes also. So these are beliefs which you think the microscope is carrying some microbes, and therefore you don't drape the microscope, everything will go wrong. This is wrong, okay? So we don't drape the microscope. What we use is we use two solutions to clean the microscope. So the biggest problem is the spores. So if you use a sporicide and if you use alcohol, it is more than enough. And plus you don't have this thing of these drapes always trying to obstruct you, always trying to fighting against the drape. So we don't. So the robot also, we use the same. We use the sporicide. There is a solution which you get. I can find out the name of the solution. You thoroughly paint this, and it is not, the only problem is the microscope switches, they say the life can be a little bit less when it comes to using the sporicide on this, and plus alcohol. So I use this on the robot as well as on the microscope. So I don't drape it. So of course, some of the surgeons, like my ENT guy, is so particular. So he's saying he cannot, when you're going transclavial, you have to drape it. And of course, we drape it. But generally, for the last 20 years, I'm not using it. And I don't have any spike in infections or increased rate of intra-op infection. So I believe this drape is more of a disturbance than, so every time I go, I use this. If it is not available, of course, if this sporicide solution is not available in this particular place, then I drape it. Now, who manipulates? I have a trained assistant who knows how to manipulate it. Of course, you cannot do both together. And manipulation of the robot is just for the positioning of the positioning. After positioning, I am using micro manipulations. I'm using the neuropilot. So I can manipulate in X, Y, Z. I can do that myself. But to position the robot to the field, generally, the trained assistant is my wife. So she is the one who puts it into the field. And if not, one of my consultants is quite trained in this. So he's the one who puts it in. So it's not difficult as you think. It's not at all difficult.
Ramesh, question?
Henry has a question.
Yeah.
Please go ahead, Henry.
Yeah. Thanks for this nice presentation. It's, of course, we have to advance technology and we have to make a first steps. I had a research project from the German Research Foundation together with a guy from Fraunhofer almost 20 years ago. And also we had a small industry robot. But in the end, it was just a very expensive endoscope holder. And we are still in the project. And I really like it that you try to improve it. And of course, in the future, that will be the right way to go. There's no question. But currently, it's still bulky and disturbing the manipulations. And I have tested all the exoscopes. I had all in my OR and all tested it. And as you said, you have to position it. The robotic arm you have to position. That is not so easy because it has its own ideas to go. And then you said you have many micro manipulator to adjust. And I'm so much used to the mouthpiece. I always go with my hand in, out. I find the ergonomic way that you have to use a hand to make a focus or go left, right. it's not very ergonomic. So it must be with a foot switch, for example, or let's say artificial intelligence. You just look with your eyes in one direction and this thing is following you, eye tracking, something like this, because I hate it if I have to bring my hands away, leave the instrument, manipulate something. If I go for surgery in places where there's no mouthpiece, I get crazy because I'm so used to it. And you go in, up, left, right. It makes it so economic and fast. And when you have the exoscope, you always have to have some buttons you push, go left, right. It takes time. But I think you are on the right way. And I'm curious to see what is the result finally. Thank you.
Henry, I can answer. I have, to your comments, I have an answer. I mean, what you're saying is absolutely right. Now, the exoscope, I don't even have to touch it because every single control, zoom, focus, everything is on my leg. So it can pivot, it can move X, Y, it can go in, come out, everything is on my leg. So I was using the Kinevo with the mouthpiece before, but for the last 1 year, I don't use this at all. I have completely given up on the Kinevo. So I am really liking the exoscope very much. And the zoom and the stereo depth is amazing. Now for the endoscope holder, I am sure it is nowhere near perfect. And I'm sure right now we are looking at a joystick with accelerometer and gyrometer so that you can wear it as a bracelet. This is an NDA with the S-Club, but I don't mind saying this to you because this is a very elite group. So we are putting it with a bracelet, and with the movements, we are trying to control. So these are the CMR guys, the Cambridge Medical Robotics guys, and as you said, AI, eye tracking. So we are trying to take the output onto a headset, which is we tried with Microsoft HoloLens. It's not possible, so we are trying it with something called XR3 Warho, which is 4K and 3D, and so you can have both the navigation images as well as the exoscope images fused. It is now done. It is already done in the project right now. It is maybe less than 1.5 to 2 years, we will be able to bring it up. So I am in the technical team for this. But of course, you have been a pioneer for this. And as you said, we have to move with baby steps. When you make a change, it's always, you have to come down. You cannot carry on with the same intent from where you are right now. You cannot carry on. You have to come down. It's a disruptive thing. So you have to come down and then take off. Eventually, you will reach a height which is way more than what this slope would have reached. So this is what I'm trying. I know it's, as you said, I had to train myself after training in the microscope, after operating with microscopes. I had to go to the lab. I had to use fruits and many other things to train first. And then after 1 month, I started getting oriented. Now I am quite comfortable with the exoscope. So it's the same thing. It will take time. It will, ergonomically, the robotic holder is not anywhere near perfect. But I think it will be the future because, as you said, AI, we would be moving between exo and endoscope seamlessly with AI. And also the navigated image, which will give, instead of this navigating in sagittal coronal, the navigational image will be superimposed in VR onto the onto your exoscope image so that you know what is behind your tumor, where is your aneurysm pointing to, where are your perforators, everything. We are already on it. We are doing it right now. Only thing is, it's not perfect.
All right. Okay. I think Imad, you want to say something?
Well, I'm running short of time, but I just want to concur what Henry said. This micro manipulator has been pain. We tried it for the past 20 years, and I think we should come with some, as you are talking about evolution and innovation, something with the foot switch or something that you can adjust it. I have one question. I've seen it used now in exoscope. What about the hybrid use with microscope? It does represent any blockage or any restriction of manipulation?
I didn't understand your question, Iman.
You are using it with the exos too.
Yes, yes, yes.
Yes, I want to ask you, for people like me, use the microscope as a hybrid with endoscopy. Does this robotic block the microscope in one way or other?
Yes, 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 absolutely. So with the Kinevo, it's a pain to use the robotic holder. To be frank, the Kinevo and the microscope and the endoscopic holder is at loggerheads. They are always colliding with each other. So it's
But I was able to do it with the pneumatic, you see, because pneumatic does not block.
I was also able to do with the pneumatic, but the pneumatic is not the way forward. So now I am combining exoscope with this, and I am able to do it much more better than the Kinevo pneumatic combination.
Okay, I think we should move on. Thanks, Aip. A brilliant talk as always. And next, it's my great pleasure to invite my very close friend, Prof. Girish Menon from Manipal, head and professor of Department of Neurosurgery. His vision is amazing, that he established several units and has worked in many places, and it comes with a wealth of experience, and this, for us, it's an honor for him to have here as well. So Girish, if you would like to carry on with your talk.
Thank you, Ramesh. Thank you for the kind words. Thank you, Imad. Thank you for this opportunity, Academy. Let me just start off by sharing my screen. Am I audible and visible?
Yeah.
Yes, yes, yes.
So I had a question for IPE actually. IPE, is there any provision where you can have a robot do the webinars for us? I think now they start doing operations. I guess they should soon start doing webinars. That will make our life much easier.
AI, maybe AI. ChatGPT is making great strides.
Exactly. So it's just a question of time that these are also going to be obsolete. Anyway, the puzzle for us, for me, especially today, is to talk about approaches to the posterior third ventricle. Now, the third ventricle, we know, is bang in the middle of a sphere, what we can call the skull or the brain. And the riddle which we need to solve is approach third ventricle, of course, without damaging anything en route. Now, this is a comic analogy which I would like to start off with. Jerry the mouse, the culprit, and that is the neurosurgeon, Tom. That's what we have the problem, how to catch the culprit down there. No disclosures, but I have few confessions to make. I wish I had good quality anatomy specimens like Abida had. So in fact, some of the slides, the anatomy slides I have borrowed from literature. Of course, I'll be giving credits from where I've borrowed. So that's a confession. And had I known Abida's, had access to Abida's slides, I would have stolen them as well. Abida, are you there? Yeah. Okay. So this is the culprit here, the posterior third ventricle, and we need to approach that umpteen number of ways. The standard ones, which are the supracerebellar, infratentorial, the Poppins approach, yeah, the transcallosal, and from the front. I wouldn't be talking too much about this because we have two speakers talking on surgery on the to the anterior third ventricle in the subsequent speakers. And of course, this is the endoscopic. I just mentioned it because I had said the way extended endoscopic skull base approaches are progressing, it won't be long before we have an endoscopic approach through the nose right into the posterior third ventricle. Anyway, to cut the story short, of all the approaches, the two standard ones are the Poppins and the supratentorial, the Poppins, the so-called modified Poppins, and the supracerebellar infratentorial approach. Before we embark upon this journey, of course, we need to know the obstacles and the hurdles that we are likely to face. And this is the center, the key. That is one from, this is the approach, this is the view from behind. That is the pineal region. So this right in the center is the pineal gland. You have the colliculi, the superior and the inferior colliculi below that, and the callosum there. And in between you have the third ventricle and the two commissures, which unfortunately are not as clearly seen as was seen in Abida's slides. And down below inferiorly, if you go, you would find the colliculi. This is what I was mentioning, the third ventricle above. And this is what you get in a wider perspective. This is the the splenium there, the third ventricle would be there, the pineal gland, the colliculi, the superior surface of the cerebellum, and medially you will have then the laterally you will have the medial part of the occipital lobes. And over here, if you chop this off, you can enter directly into the atrium. That's the neural structures. Coming to the vascular structures, which are equally important, especially in this area. A lot of veins, but fortunately not many arteries. The one single artery which I would mention first is the medial posterior choroidal artery. Of course, the veins, I would talk about them in detail later. Fortunately for us, most of them are above the pineal gland, and more importantly, what I wanted to highlight is we do not see them as such. Almost always there is a thick arachnoid coating over all these veins, so very difficult to identify which is which. Always you need to work between the arachnoid to delineate the veins. Actually, in many instances, we do not need to dissect them that much either. And this is, of course, the gross appearance which you would find from a posterior approach, the cerebellum, and you separate the occipital lobes to reach the posterior third ventricle. Something more about the veins here, I just wanted to highlight. So if there's the splenium over here, you have the inferior cerebral, the internal cerebral veins, and the basal vein of Rothschild joining, and then you have the vein of Galen, which kind of ascends up behind the splenium. It's so very important to know that anatomy and the lie of the vein of Galen and the internal cerebral veins, but because this is what we seldom see the vein of Galen directly, especially when you go from a posterior supracerebellar approach. What you find, the large ones are sometimes the precentral cerebellar veins itself are so large, like you see in these cases, and you mistake them for the vein of Galen, which is usually shifted up, especially if you have a tumor in the posterior third ventricle region. So this concept of anatomy, that you will find the vein of Galen above, you might find the precentral cerebellar veins coming on the way, and the internal cerebral veins on the lateral aspect we need to be thorough about. The view from the lateral side, again, just wanted to highlight the course of the internal cerebral vein. This is the internal cerebral vein over here, the basal vein, the joint to form the vein of Galen, and this over here is the pineal gland. So all these tumors, which fortunately the internal cerebral vein, I wanted to highlight, as well as the choroidal artery, which I mentioned earlier, they lie in the velum interpositum, which is the space between the two tila choroidae on the roof of the third ventricle. Fortunately, most of the tumors arise below the velum interpositum. So most of them are over here, and then they push the veins above. That's why majority of the approaches, majority of the surgeons, in fact, prefer the supracerebellar approach. Now, of course, the tent comes in the way. This I just wanted to highlight this particular the sagittal section, because the tent adds to your obstruction. Because if you have a tumor which is bilateral, which is going to the opposite side, especially in the modified Poppins approach, where you're going from one unilateral side, you will find this as a stumbling block. The contralateral side becomes hidden for us. Now, if you enter from the ventricle, from above, from as you do in third ventricular approach from the front, this is the classical view, what you find. But what I wanted to highlight here is the habenula commissure and the aqueduct, which you would find in the posterior third. I wouldn't go into too much of that, because I'm sure my subsequent speakers would be. So this is the vision you have when you approach the posterior third ventricle through the lateral ventricle from anteriorly. Just to highlight that again, and an endoscopic view, because most of us, that is what is approached, what is the common approach done now. This is what you would find, the posterior commissure here and the aqueduct here. Now, coming to the essence of the core of the topic, that is choice of approach. How do you decide on, you have the multiple approaches, and how do we decide on which approach to take for an individual case? Now, most of the posterior third ventricle tumors usually cause obstruction of CSF pathway and come along with hydrocephalus and its associated symptoms. So CSF diversion is a key element in the management of these patients. It could be in the form of a shunt surgery, or it could be in the form of an endoscopic third ventriculostomy. And many a times, especially the histology is kind of known on a preoperative MRI, especially in cases of germinoma, which have a characteristic MRI appearance. We can get away with an endoscopic third ventriculostomy and just a biopsy. And then, of course, all these tumors respond, many of these tumors respond very well to adjuvant radiotherapy. So the goal of surgery is not, what I wish to highlight is that not all posterior third ventricle tumors need to be aggressively managed with a surgical approach and with a gross surgical approach with gross total resection. Many of them we can get away with just with CSF diversion and a biopsy. Of course, when you attempt to do a CSF, a third ventriculostomy and a CSF and a biopsy in the same setting, it can be a little tricky, as is shown in this picture, because the trajectory we need is little different. The burr hole we need to do for a third ventriculostomy is little posterior compared to the burr hole we need to do for a biopsy of the posterior third ventricle. This is very well illustrated in this picture, but sometimes we can get away with a single burr hole, as is seen in this video, which I would just like to show. So, so this is a third ventriculostomy being done. It's just in front of the mammillary bodies. You can do a good fenestration. You can see the basilar pulsating there. And then we turn the scope posteriorly. And you can see the tumor sitting over there. And you can do a biopsy from the posterior third ventricle tumor. So many of times when I prefer to do 2 burr holes, because I find angulating the endoscope posteriorly from the burr hole done for third ventriculostomy a little difficult. So I generally prefer 2 burr holes when I attempt a biopsy from the posterior third ventricle. Now, the second aspect on how to decide on the approach is, as you say in this case, you can see where is the epicenter. The next parameter. So first is the goal of the surgery, whether it is CSF diversion and just biopsy, then an endoscopic approach would suffice. But in this case, as you can see, you have a tumor here in the posterior third ventricle. The epicenter of the tumor is towards the posterior aspect, towards the pineal region. So if the epicenter of this tumors are naturally, the corridor has to be from behind. And as it's seen in this case also, corridor from behind. And in this cases, if other parameters are comfortably located, suitable, as I would be highlighting later, you choose an infratentorial supracerebellar approach, the classical crosses or the stains approach. And this is how we go about it. And this is generally, I prefer a prone position. And once we do a craniotomy or a craniectomy, either way, we have multiple veins coming on the way. And as Abhida was showing, she was mentioning about using a supracerebellar approach for even a mesial temporal lesion. We also prefer to go from one side unilaterally, because quite invariably we end up buzzing a lot of veins en route to the pineal region in this approach. So it's preferable to go from one side, the unilateral side. And as you can see here, the initial part is a struggle until you get into the tumor, until you decompress some part of the tumor. Space is limited. In the entire field, the tumor is seen in a very limited space. And even in a sitting position, the ergonomics for the surgeon is not comfortable. Long working distance, the hand, you need to stretch your hands too much. And in case there is a venous bleeding, unfortunately, you have a difficult time. But the advantage of this approach is a straight, simple midline approach. You just reflect the cerebellum downwards, you bang on the tumor, and the veins generally, as I mentioned, are pushed above. So the advantage is that the veins do not come in the way. But again, as you can see here, you have this venous oozing coming in on in between. And one drawback is the tumor is just in front of the vermis. That is a blind area. So this is good for relatively small tumors. This approach is bang in the midline without much of supratentorial extension. And the advantage is, they said, natural effect, especially if you're using a sitting position, there's a gravitated retraction of the cerebellum and you do not violate any neural structures. Of course, you need to work between the veins and you might end up coagulating a few supracerebellar veins. Now, this have a tumor like this, a large tumor, multi-compartmental, supra and infratentorial tumor. This tumor, it's not that big, but you can see the bulk of the tumor is in front, is inferior, posterior, inferior. But as I said, this area is a blind area for a supracerebellar approach. You have a large tumor, unilateral with extension to one side. As you can see here, it is more onto one side. And if you suspect that it's going to be a vascular tumor, the approach I prefer is a supratentorial modified Poppins approach. Even for other tumors, which some of the tumors which are amenable for a infratentorial supracerebellar approach, one of the obstructions which can come is the angle of the tentorium. Like in this tumor, it appears suitable for it's a small tumor, good case for a supracerebellar approach. The angle of the tent is so very acute, and that can be a problem for a supracerebellar approach in such cases. So I'll just a bit about measuring the angle of the tent. There are different ways, the one which we follow is draw a straight line from the colliculi along the floor of the fourth ventricle, draw perpendicular to the torcula, and if the angle is more than 60, we usually assume it to be a steep tentorial angle. Now this is an angle, if it is too steep, obviously it is a make the supracerebellar approach a challenging one. So in such instances, where the tumor is too large, tumor has a large supratentorial extension, tumor has a unilateral extension onto one side, we prefer the occipital transtentorial, the so-called modified Poppins approach. Now there's a lot of history behind this approach. In fact, it was somebody before Poppin who advocated this, started way back in the 60s. It was Jamaison who added the tentorial cut part to the modified Poppins approach. And the different positions have been advocated. Some people do it prone, some do it sitting, some do it 3/4 prone, some use the Concord position. We generally use the 3/4 prone position. And this is the approach, this is the view that you get once the craniotomy is done. You have the, you can see the superior sagittal sinus, the straight sinus, the tentorial edge. And as you progress, the drawback with these approaches is unless the brain is lax, you have to do a bit of occipital lobe retraction, which can result in some visual field defects. You need to work between the veins because, as we discussed earlier, when you go from above, the veins generally come in the way. And the more bigger challenge, as I said, is in many instances it is a thick arachnoid covering over the veins, which are not as easy as you dissect a Sylvian fissure, where you open the Sylvian fissure and you can separate the arachnoid. The veins over here are sometimes they're really thick and quite difficult to dissect the veins from the arachnoid over here. And the drawbacks about this with this approach is, as I said, if the tumor is going far inferior, you have a challenge. There is too much tumor going to the opposite side. Again, that becomes a challenge with this approach. But the advantage is you have a large working area. There's a good exposure, especially if you're anticipating a lot of bleeding. It gives you enough space, like in sharp contrast to the video which I showed earlier, where the operating area was just 20% of the entire view. Here you have this entire field comes into picture, and it becomes much easier when in case of you have vascular tumors where you have a lot of bleeding. These are the drawbacks which I said, working between the veins, and in some instances you might damage the splenium as well, resulting in some disconnection syndrome. But there are some alterations which different surgeons advocate, depending on which side you want to keep the operating side down or the operating side up. We prefer to keep the operating side down because that helps in retraction of the gravity-aided retraction of the occipital lobe. And much more difficult than that is cutting the tent. Although it might be an easy maneuver in many cases, cutting the tent to give more exposure can be challenging, because as is seen in this case, you can have a lot of veins, unnamed veins under the tent, especially in patients with raised ICP where there's a general venous engorgement. Cutting the tent can be a challenging maneuver. So this is another drawback of a modified Poppins approach. Now, when the epicenter is within the bang within the third ventricle, you have a tumor arising from the posterior third ventricle, but which is progressing anteriorly, especially the cutoff mark is tumors which are anterior to the interthalamic, the massa intermedia or the interthalamic adhesions. In such instances, obviously, you need to take a anterior approach through the third ventricle, through the lateral ventricle. A transcallosal approach is what we use. Enter the roof of the third ventricle, and in some instances, again, if like in this case where the tumor was relatively large, suprachoroidal approach into the roof of the third ventricle gets you bang into the tumor. And fortunately for us, this was a not a too vascular tumor which just kind of popped off. I wouldn't be going into the anterior third ventricle approach because Henry and Eckhart are speaking on those approaches in the subsequent talks. So in cases of posterior third ventricle tumors which have a significant anterior extension, which extend anterior to the massa intermedia, this approach through the callosum is an alternative to the posterior third ventricle. Now, this is one approach which has been described off late, a posterior transcallosal approach. Now, transcallosal was the first approach described by Dandy, which again fell out of favor because of the complications associated with splenial and the callosal resection in that area, especially the disconnection syndromes and so forth. But now Aaron Cohen's team has come out with this. I must confess that I do not have personal experience operating in this manner, but this posterior transcallosal approach to the final region and the posterior third ventricle via the intervenous and the paravenous variants. So this probably is a alternative to the posterior third ventricle, some of the lesions here. I must confess I do not have much experience with that. Having said about the three major approaches, that is the Poppins, the supracerebellar, and the anterior transvelum interpositum approach, I just wish to mention the other approaches, which are most of them kind of become obsolete. The transventricular approach by Van Wegenen, but especially important if there's a large component which is extending into the atria. You have a combined approach, supra and infratentorial approach by Laligam, Shekhar, and Zial, especially for very large tumors. You have a lateral paramedian infratentorial Van Wagenen's again approach, but these are limited to very small tumors where you can just go unilaterally, expose the posterior fossa, but you go unilaterally from one side. And the posterior transcallosal approach by Dandy, which was the landmark approach, which again fell out of favor because of the associated complications. But to cap it on, the most important decision is the surgeon's preference and his comfort level. As I said, there are multiple variables, the angle of the tent, the size of the tumor, the vascularity of the tumor. The most important is, so here I'm just showing a video of a position of my friend, Dr. Vernon from Mumbai. This is a very unique position. It's neither sitting nor lateral. It's a lateral sitting position which he adopts, which he finds it ergonomically comfortable. And this is just a position as he had. I have not done this approach, but I would wish to try out this approach because for a supracerebellar approach, this looks like a comfortable approach. Now, all this is based on my personal series of 66 cases of posterior third ventricle tumors. But as you can see here, it's just 38 cases where I've gone in for a major craniotomy and approach. Majority of the times I've got away with an endoscopic third ventriculostomy alone, like a small tectal glioma, which causes secondary acute stenosis. All that you need to do is a third ventriculostomy and wait and watch and go in if the tumor increases in size. Then, of course, in cases like germinomas, all you need to do is an ETV with biopsy. So almost 20%, 1/3 of my cases, I could get away without doing a major surgery. And of course, stereotactic biopsy, I must confess, I've just done one. I find it challenging going into the third ventricle, posterior third ventricle, doing a stereotactic biopsy. So crosses and pop-ins just constitute maybe 1/3 of my surgical approaches. So to summarize, I would conclude, whatever be the approach, the initial access is limited. And as you progress, you get more, and as you start decompressing, you get more and more space, and that is what gives you better corridors. So either the infratentorial supracerebellar approach and the pop-ins approach, if you're lucky, the initial part is hazardous, but as you decompress more and more tumor, you get a lot of space, and then you find that to be both to be a comfortable approach. Biopsy or gross total resection, either go for either biopsy, or if you're going in, try to go in for a gross total resection. A subtotal one can be risky, as I experienced in this patient. This is what happened to my patient. Somehow I left behind a bit of the tumor bled, and this patient with so much of the blood clot thereon and so much of diencephalic edema, is just not recovered. In fact, after 6 months after surgery, still remains in a kind of vegetative state. So my suggestion would be either go and do a biopsy, or if you're going in, try to be aggressive and try to take, or not to leave a small bit of residue which can bleed and create problems. CSF diversion alone may suffice in many instances, and we need not be very aggressive about taking all the tumors out. And of course, the bottom line is the surgeon's comfort is the key. Just few of the articles from which I borrowed some amount of literature and photographs, and of course the master anatomist whom we are all indebted to. Thank you.
Thank you. Thank you, Girish. It's a comprehensive review of that approach, and you discuss the dilemma when you choose the approach, whether to go above or below or different approach, as we all go through in some of these cases. When it comes to a decision-making process, would you give priority to the venous displacement or the extension of the tumor or the tentorial angle? Do you have any sort of priority in such cases?
The tentorial angle I would rate as supreme for me, because as I said, the other parameters, once you're in and you start decompressing, the tumor gives you space. But the initial part is the challenge. The initial half an hour of the surgery until you reach the tumor and you start decompressing a challenge. And the tentorial angle, if it is so acute, that initial part can be really difficult. And especially in an infratentorial supracerebellar approach, the moment you put the retractor, you have 1 or 2 veins snapping here and there, the entire field becomes bloody and the cerebellum starts swelling. The surgery can be really messy. So in such instances, I go err on the other side and try to go supratentorial through the pop-ins approach. Otherwise, my first instinct is generally to go supracerebellar infratentorial.
Yeah, thank you. Imad?
Yeah, I just want to draw to a red flag for, in this germinoma, putting a shunt early. These tumors, we know they metastasize. Don't commit the patient early for shunting. EVD is a better while you are sterilizing the CSF with chemotherapy, or if the age permit, radiation therapy. I did have in my previous complication a patient who developed metastasis with peritoneal metastasis 9 months after, and because we were late, we were early putting the shunt, we thought the radiation will start immediately. They delayed it 6 weeks. By that time, the lesion metastasized and it will become too late. So please put an EVD to start with, first to evaluate if you need the shunt or not, rather than to put the shunt. I know many institutions, especially in less privileged country, they make it easy. Let's put the shunt and finish it, and then we can give the treatment. No, EVD, and ask your oncologist to take care of that tumor, and then you, if you need, you convert it to a shunt.
Right.
Yeah. It's seldom do a shunt. In fact, in my series, there are 4 shunts, which is done in the initial part before we had much experience with the endoscopic third ventriculostomy. Shunts are seldom done now. So ETV, send CSF for tumor markers. If possible, get a biopsy through the same endoscopic approach. And if it is something like a germinoma sent for adjuvant therapy. That is the protocol.
Okay,
Of
thanks.
course, with a lot of biomarkers, so markers for tumor markers for posterior third ventricle tumors, decision making becomes easier.
Okay, Hick?
Brief comment. I very much like your presentation. I think pointing out that the tentorial angle is so important for your access and viewing is really important, especially for someone who starts in this field. But for me, I get pre-surgical CTVs on every single case, because I've learned from tentorial notch meningiomas that if the veins are displaced superiorly, I want to come in from below. The veins are depressed downwards, I want to come in from above, irrespective of the angle of the tentorium. So I thought that was just one comment. And then in terms of engorged veins of the tentorium in cases of hydrocephalus, there's a good way of using wet clips on each side. So if you split the tentorium in a tiny spot and then you put clips on both sides, you can divide it. You don't have any problems with bleeding. So that's just a hint for practicality for folks that get into this area.
Okay, Vladimir?
Yeah, Girish, that was excellent. I have only remarks to supra-infra approach. Over the past 10 years, I use only unilateral. There is no need for a midline approach. If you come from the laterals, the way is shorter and you see everything what you see with the midline, and you do not need to cut the Vermean veins. And the next point is that you said that the sitting position is not ergonomic. You are perfectly right. You need to have long arms to reach the space. Just recently, I have learned to use the exoscope. If you put the head of the exoscope into your lap and the screen just above the head of the patient, it's extremely comfortable. You have flexed arms and you see from below with the help of exoscope, something microscope doesn't allow you to do.
Thank you.
Thank you.
Thanks very much. I think for sake of time, we'll carry on. Ek, you want to call the...
Sure, it's my pleasure to introduce one of my friends. Henry Schröder is going to give us a talk about the anterior portion of the third ventricle, and I'm looking forward to some exciting endoscopy from you, Henry.
Let's see. So my talk was, in general, approaches to the third ventricle. So the region of the third ventricle, we have heard a lot of that before. There are many ways to go there. You can come from enonasal, lamina terminalis, transcallosal. You can come from interhemispheric occipital or supracerebellar infratentorial. So many ways to go there. I think it's very important that we really look at the anatomy, that we study the MR images before we make the decision. Our guys from internal medicine, they always celebrate, they do now individualized medicine, but we do it since 20 years already. Each surgery is planned individually, and there are many factors which influencing the approach: the size of the ventricles, the tumor location, tumor size, vascularity, individual anatomy, aim of surgery, and of course, surgeon's experience and pre-reference. So for most cases, if possible, we try to use the endoscope because it's really a minimally invasive approach. We use a lot of ventriculoscopes. There are two different sizes. It depends what you want to do. For tumor resections, we take the larger ones, the smaller ones for ETV or biopsies or just septostomy. And for me, very important is that I have an endoscopic sheath, because this I use as a retractor to create some space, to put it on bleeding spots for the hemostasis. So it's a very important part for me. And then we have an optical trocar, which is put into the endoscopic sheath. And if you have a small foramen of Monroe, you can use it to dilate it a little bit. Of course, when the foramen is much too small, you should not do, because you rupture the fornix. But if it's just, let's say, 1 millimeter, then you can dilate the foramen and you can go in. So approach for colloid cysts has changed. We go more laterally and come more anteriorly to have a good view to the upper part of the third ventricle, because at the roof is the cyst tucked up. So if you come from here, you don't see it. You see the floor, but we want to see the roof. So we come from anteriorly and laterally. We just slide over the head of the caudate nucleus. And then we have this view to the foramen, and we can manage it nicely. The only exception is if you have a septum, a cavum in the septum pellucidum, then you can come on top. You see the foramen itself is small. If you go through the foramen, it's not good. The fornix is stretched over it. And then here we open the one layer of the septum, and then we are on top of a cyst, and we can remove it. This is just one case, but I will skip it for time purposes. We use navigation to come in, anterior location, and then when you're in the ventricle, you see there's some coral plexus over it, but it's not a big problem. We coagulate the coral plexus, and then we can remove it. And another example is a patient with gelastic seizures and rage attacks, and he has this hypothalamic hematoma. And you see he has very, very small ventricles. Of course, you could come transcallosal or translaminar terminalis, but of course, endoscopically is also an option. So hematoma is on the left side, so it's better you come from the right side. And also the ventricle is larger on the right side, but you see there's almost no foramen, and there's a big vein in the foramen. So under navigational guidance, we go into the ventricle, and then you see the foramen is almost completely closed. You have a very thick thalamostriate vein, septal vein. You see when I go with my sheath, I would rupture the vein or the fornix. That's why the first step to do now is to make a foraminoplasty. So we dilate the foramen a little bit with the Fogarty balloon catheter. And then we take this optical trocar, which has this conical shaped tip, and then we can slide under the fornix into the ventricle. And you see this is a hematoma. There is the floor, mammillary bodies here, chiasm. And this is a hematoma. And then we make a deconnection of the hematoma. This grasping forceps. And then we take a piece for histology through the working chair. And this is a little otoscope, of course, a small one, because the foramen was so narrow. And then you see when we go out, there's no damage to the fornix. So with this conical shaped trocar, we could invert the sheath without causing any damage and could resect it. So this is, I think, a nice tool when you have a small foramen. So this lady came with obstructive hydrocephalus, and you see she has a small lesion exactly in front of the aqueduct. The floor is bulging downwards, a typical occlusive hydrocephalus. So many people say, yes, we make an ETV and then we take a biopsy. But I think this is not needed because it's a small tumor. So what we do is just we make a borehole far anteriorly, and then we go through the foramen of Monroe. You see this is the floor, this is the aqueduct. So within 10 minutes, you are in front of the tumor, and I think everybody will agree that it's the least traumatic and easiest way to get access to the posterior third ventricle. Of course, this is a rare lesion because it's so small. Usually the tumors are larger. But if you have such a small tumor, there's no need for ETV. We just can address the tumor, we get the histology, and we can restore the aqueduct and have a restored CSF circulation. Some bleeding is controlled with bipolar diathermy. And then after resection, you see posterior commissure and the aqueduct is completely free. And this turned out to be an ependymoma, so no other action was necessary. So if you have small lesions, we don't need to make CSF diversion, we just remove the cause of the problem. Now we come to endoscope-assisted cases. When the tumors are too large, then I think the use of the endoscope makes no sense because it's time-consuming, and then the microscope is still the better tool. This was a 5-year-old male with seizures and headache. And he came to the MRI and they just described the arachnoid cyst, but they did not describe this one. Then he was sent home. And then after 10 days, he had again vomiting headache. and he went to the pediatric department and they just make a lumbar puncture without imaging and discharged him again. And then after another 8 days, again vomiting and headache, and then they make images, and you see the tumor has grown massively and has obstructed hydrocephalus, and EVD was then inserted. And then the parents contacted us and they wanted to come to my place. So the child came with an external drain to our place. You see, alpha-fetoprotein is increased. He came to us. We make another MRI. You see, tumor even grow larger. It's a very fast-growing tumor. What we did is we make ETV and septostomy, but our oncologist said, please don't take a biopsy. This will just spread the tumor in the ventricular system, and we know what to do because of alpha-fetoprotein is so much increased. So we did this, and when we have made the last skin suture, he started already with chemo. And you see here's a good flow in front of the tumor. So he started immediately with chemotherapy, 2 blocks, and then high-dose chemo and stem cell transplantation. And then tumor was still growing and obstructing both foramina of Monroe, so a shunt was required. And then they continue with the chemotherapy, and you see the tumor was still growing, bulging into the foramen. And then chemo was ready, and then it was our task now to remove the tumor. So what is the best approach to come to this lesion? I think the tumor is bulging into the foramen. So what we said is the best way is an interhemispheric transforaminal approach. So we came a little bit more anteriorly through the foramen of Monroe. Tumor resection in November 2015. So we see the right hemisphere is a little bit down. So the hemisphere falls down by gravity. We look into the dilated foramen of Monroe. And you see there is a typical teratoma. We found a teeth, some hair, some mucous material. So we make a resection. Ultrasonic aspiration was not so much working, but you see there is a nice plane between the tumor capsule and the normal. Here you see the tumor, and this is a normal gray wall of the third ventricle. So we could go around and could dissect the tumor very nicely from the surrounding structures. It was very fibrous. This is a telechoroidea where the tumor was rising initially. You see some vessels here. This is the roof of the third ventricle, but we could see everything. Then the third ventriculostomy, we enlarged it once more. And then with an endoscope, we looked into the area where the attachment of the tumor was initially, and we could not see any residual tumor. Here, this was the area where the tumor was arising initially and was not seen in the first MRI. And this is a post-op MRI, shows gross total resection, small callosotomy, it's visible here. He was very fine, and now he's almost 8 years after surgery, and he's still doing well. But was a very aggressive growing tumor. Another case was a 16-year-old male, gain of weight, headache, vomiting, and you see this kind of tumor bulging down into the cistern, very close to the basilar and the perforators, and very close to the stalk here. Endocrinologically, he was okay. He had a little bit of obesity, a sign of hypothalamic involvement. You see here, the border was not very good. You see here, it goes in, but on the other side was a very good border between tumor and the hypothalamus. So which approach is that the best for this one? And if you see there is a septum, a cavum in the septum separated, then the interfornicele approach is very nice. If it's not, if the fornices are close together, I would not cut in between because you will destroy or at least damage the fornices. But if you have this and you have the separation of the fornices, then transcallosal interfornicele approach seems to be a very good approach. You see here, there's a cavum. That should be the best approach. Transcallosal interfornicele. Of course, if you have a case with this ventricle, with this fornix, please don't cut here through. I think this is not good because you damage the vasculature and everything. But in our case, it looked like this. You see, fornix here, fornix there. And then you have plenty of space that you can cut the tela in between, and you have direct access to the tumor. And then you can dissect it. Of course, we did not intend to have a gross total resection because of the neighborhood to the perforators and also neighborhood to the infundibulum. So we did not want to make him panhypopit, and don't want to have a damage to the perforators, of course. But you see here, on this side is a very nice plane. On the other side, it was not so good. But what was expected from the pre-op MRI? So ultrasonic aspiration is very helpful to follow the border. And then you see there's a big hole in the floor of third ventricle. You see the basilar coming here, SCA, P1, and here are all the perforators. So then we stopped. Just we make a wide third ventriculostomy if you wish. So we left tumor here to the perforators and to the infundibulum. But the approach interfornicile was ideal in my opinion. So this was another guy, 15 years old, had double vision for 2 years, headache, vomiting, had multiple shunt procedures, and always was considered to have an inoperable tumor. And he came in with this huge tumor. So the third ventricle is filled, and the fourth ventricle is all this tumor. Here's a little bit residual tactile plate, but it's a huge tumor. But we said, of course, we can try to resect it. You see here is the MRI. You see here, this is a tactile plate, dilated. And again here, you see good border to the wall of the hypothalamus. So the approach in this case should be a transcallosal, transchoroidal approach. So we don't go in between the fornices because they were not separated to come in this area. So we go here. Tenio fornicis is chosen to come in between the internal cerebral veins. You see, I've seen it's a huge tumor. So we have to open the roof of a third ventricle widely. See, here is one of the internal cerebral veins on the right side. So we cut the tenure, and then we go to the tela choroidea in between the veins. This one vein, the other vein is on the other side. And then we have a wide access of the whole third ventricle from anteriorly to posteriorly. You see this, the infiltrated floor of the third ventricle with mammillary bodies. Of course, we stop here, but we had a good plane, ultrasonic aspiration. We can come. When you remember the first image, you see that the floor of the third ventricle is very thin. So the midbrain in this area is very, very thin. So we have to be very careful that we do not perforate through this small remnant of the midbrain. So ultrasonic aspiration all the time. And then we could look from above into the fourth ventricle. You see here is a big hole because the tumor dilates everything, and we look here to the fourth ventricle. When we go again with an endoscope inside for inspection, we go in here. You see here is the fornix on one side, anterior commissure, other fornix on the other side, and then we look back, internal cerebral veins, and down here we can look into the fourth ventricle, which is widely open here. So after surgery, was deeply comatose, no response, Glasgow Coma scale 3. Pupils were equal and constricted. And we make immediately MRI, also with diffusion to look, is there any infarct? No. And you see here, this is very thin. And this is the area where the reticular formation is, which is responsible for consciousness. So he was in coma. And then this stayed for 10 days. And each morning I came to the patient's bed. The mother was looking at me and asked, what is with my son? What's my son? And I really, after 3 days, I became also nervous because the patient did not became awake. And then after 10 days, he started to obey commands, open the eyes, had a left hemiparesis, but this improved. And then after 20 days, he was first time to walk with physiotherapy. And 1 week he could walk alone. And then he was improving, but it was a long time. and thinks the reason for this is that the formatio reticularis was damaged during the surgery. But finally, he could be discharged at home. And you see, this is 3 years later, no recurrence so far. Another patient, 29-year-old male, fatigue, decrease in performance, partial insufficiency, has this tumor filling the third ventricle, a little bit hydrocephalus. And if you look from this side, you see the whole third ventricle is filled with tumor. What is the best approach? Many people say, of course, we come here transcallosal. But if you remember and look at these images, you see when you come here transcallosal, you have to be very careful because the fornix is stretched over the tumor. It's not much space. And in this case, we have here the gland, and this is the optic chiasm. So in this patient, we have almost 1 centimeter space between chiasm and infundibular pituitary gland. And the longitudinal axis is in this area. So that's why in this case, we chose the endoscopic endonasal approach. So the skull base is open, dura is open, optic nerve left, right, clinoidal carotid, this is a gland. So we open the arachnoid, you see branches of the superior hypophyseal artery supplying the chiasm. These, of course, have to be preserved. Then we open it. This is a tumor, looks typical like a craniopharyngioma. And what is around is infundibulum. This is not a tumor capsule. So we just take the tumor. Ultrasonic aspiration was helpful because the tumor was not too firm. But you see here, this is all infundibulum. And now the tumor did not came down. So we used a 45-degree endoscope and traction counter traction. And we stayed in this gliotic plane, which was around the tumor. So we never ended up in the white hypothalamus. So that's why we continued with the resection by manual traction counter traction. I think very important that you not simply pull on it because you never know where it's sticky to. And here my forceps could not reach the upper pole of the tumor, so I have to bend my suction to go up to the almost to the roof of the third ventricle to go around. And only after we have dissected the tumor completely, it's removed through the nose. I think this was an ideal approach because I did not touch anything of the brain tissue above. This is a posterior commissure, fornices, foramina of Monroe. An MRI shows gross total resection. This is our nasoseptal flap. And now he's 8 years after surgery. No recurrence so far. And the good thing is he had no obesity. Of course, he's panhypopit, even though we tried to preserve the infundibulum, but because of the involvement of the tumor, this was expected. And the last case, 10-year-old boy, headache vomiting, has a huge pineal cyst, compressing the aqueduct, ventricular dilation already. You see hydrocephalus here. So the approach from which side should become, we make, like Vlad said, we make always a unilateral, small craniotomy on one side or the other, and on which side we should do it. It depends from the anatomy, especially the height of the transverse sinus and the bridging veins. And you look at this boy, you see this sinus is much deeper than this one. So the angle from here is steeper. So I go to the sinus, which is higher. And then you see here's a bridging vein, but here is no bridging vein. So that's why in this case, we come from the right side. And also one argument is that in the midline, it's very steep. And the more you come to the side, you have a very shallow angle, and it's much easier. Positioning, we like to have a sitting position, paramedian incision. I have long arms, so for me, it's not a big problem. Of course, PVO, we have to make sure there's no open foramen ovale. If it is so, we put in the Concorde position and make the surgery in the same way. So this is our opening. We just have a 2 centimeter opening. We cut parallel to the transverse sinus. So there is no cerebellum protuberant through the dural incision. Then we open the arachnoid. We open the cyst, and then just with 2 forceps, you have such a nice plane, and you have this clean area of dissection. We just need 2 forceps to dissect. The telachoroidea is coming. This is a habenular commissure. which is carefully dissected by manual techniques. This is the other side on the thalamus. Just with 2 forceps, we deconnect the cyst and we take it out. And this is for 3 months post-op. So conclusion is third ventricle. There are a variety of approaches. And of course, you have to select it according to the individual anatomy. You look at the MRI precisely, and then you can choose what is the best approach. Microsurgery, most of the time we use a transcallosal approach. If we have very wide ventricles, I also like to have this tube, which is nice. It's a 12-millimeter tube from Vigor. You can just insert it through the endoscope tract. And in large ventricles, we use this transcortical tube-based approach, and final lesion, supracerebellar infiltratorial unilateral approach. Thank you for your attention. Any questions?
Just a comment. It was fantastic as always. I love your imaging and how you embed the endoscope. And I think best lesson learned from your presentation for me was how you individualize approaches based on, you know, the anatomical viewing angle. And I thought it was really well done. Thank you.
Fantastic presentation, Henry. Beautiful.
Thank you.
Looking forward to handling that.
Yes, me too. Much more exciting, hopefully.
We move on. If any other questions, I'll ask my great friend Eckhard Kasper to share the screen and talk on the strategies for intraventricular tumor surgery.
Yes, thank you again for having me. And I apologize for those who have seen part of this presentation in Jerusalem. The first half may be familiar, but I try to shrink it down. And then I had a bit of a mishap. I tried to upload too many videos into my PowerPoint and it died overnight. So I'm going to split it. I changed the PowerPoint to have first still images of pictures that I took throughout the case. And then afterwards, we go into a different screen share and I can upload them, the videos directly from the recording site. So I want to give you some ideas about preparation and execution of intraventricular tumor surgery. I limit myself to a lateral ventricle. These are my disclosures. I'm lucky to work in a good environment surrounded by outstanding institutions. I want to just give you a little bit of background on the anatomy and the pathological landscape for this. And then I want to give you surgical scenarios for intraventricular tumors of the atrium, right versus left side. And then for a very large tumor, what I consider a top-down approach. And at the end, we can have a discussion. If we really have a lot of time, I put on one outstanding case afterwards. So coming back to intraventricular tumors, your lifetime risk to develop a CNS neoplasm is only 1%. And hence, it's not likely that you will suffer one yourself. But incidence seems to be increasing. Amongst the brain tumors, primary brain tumors, intraventricular tumors are truly a rare problem. Only 1% are located strictly in the ventricle, and if so, most frequently in the trigonum or atrium. But 10% of these tumors involve the ventricle, hence it's worthwhile knowing the anatomy, because you will encounter this much more frequently with other tumors where you need to get around the ventricle. Are these tumors a challenge? And I think, as we've heard before, most of us here on the panel agree that they are challenged because a lot of these are rare. They are surrounded by high real estate, and experience is lacking in most sense, especially at the beginning of your career. So it's hard to get into something that you consider dangerous, but at the same time, don't be scared. If you follow some principle, it works really well. This is one of these tumors. I just want to show you up front. It's flipped for the navigation system. You see the left side on the left side, and you see this cauliflower type of lesion sitting in the left atrium, filling it completely with mass effect anteriorly, partially calcified, partly non-calcified, and the lesion is hard to gauge initially. So this is a challenge. So let's break this down into different steps. First of all, we want to classify the lesions. Our radiographic features are good for delineation, whatever you pick, CT, MRI, PET scan, SPECT scan, but they're non-specific. So you can't always predict the pathology from the radiological imaging. The location of the mass and the patient's age provide the most helpful information in the differential diagnosis. And when you look at these, and for today's purpose, we want to limit ourselves to meningiomas, because these are some that you will encounter in your practice. Well, once we classify the lesions, it's good to classify them by where they arise from. So a subdivision based on, does it come from the ventricular wall, from the choroid plexus, or mixed, has helped me a lot. And for today, we want to limit ourselves to choroid plexus lesions. And here, meningiomas in the adult patient population are the most frequent tumor types. In pediatrics, it's more papilloma and plexus carcinoma. And of course, metastasis can mimic anything. For meningiomas, background, know that 80% of those in the ventricle do occur in the lateral ventricles. There's, for some odd reason, a predilection for the left side. Gender predilection is not different than other meningiomas, 2-to-1 in favor of females. And these tumors make about 0.5 to 1% in most tumor surgery practices. But in pediatric population, up to 10 or 12% of intraventricular tumors may be meningiomas, so be aware. The clinical presentation is mostly with general symptoms: headache, nausea, vomiting, dizziness, and seizures occur quite frequently. Once the tumor is large, there may be focal symptoms depending on the direction of growth, and that can be weakness, sensory changes, or on the left side, aphasia. Occasionally you find odd symptoms such as tinnitus or apraxia if it presses on the cerebellum inferiorly. Now you have to recognize one syndrome, which is the syndrome of the trigone, which is a large tumor in the trigonum, will cause a combination of weakness on the contralateral side, hemianopia, and if it's on the left side, dysphagia. And I'll show you that in a second. History, this is quite well described early on by Dandy. He started in the 40s to operate on tumors in the ventricle. And this is one of his famous pictures where he takes out a large ventricular tumor by hand through a parietal transcortical approach. Surprisingly, the patient survived, because if you pull on the vessels, you expect there may be disaster afterwards. But he did start pioneering a lot of the ventricular surgeries. Now, if you want to read one paper for the readership here, this is the one paper I recommend to everyone: Surgical Approaches to the Atrium of the Lateral Ventricle. This is really coming out of Roton's group and was written by Kawashima in 2000, updated in 2006. And today we want to focus on posterior transcortical approaches versus occipital approaches, because this represents for me the best approach to the right side, whereas the occipital approach I prefer for the left side. And as I often say, what you try to do here is to steal the bird out of the bird cage without really opening too many of the beams. So we'll see how we do this. You should really review the topography and review adjacent structures and vascularity preoperatively. So of course you need to know the anatomy of the ventricular system: posterior horn, inferior horn, superior horn, adjacent. And then if you look from posterior, superior into the ventricle, anterior to the ventricle, you have the caudate. Anterior medial, you have the thalamus, posteriorly the pulvinar. In between runs the choroid plexus, and next to it runs the fornix. So you're next to high real estate, and you really want to be careful in this location. This is a beautiful picture by Wang looking into the left ventricle from posteriorly. And just as I said before, orient yourself in the midline, the corpus callosum, the glomus of the choroid plexus here, the thalamus in front of it. The body of the lateral ventricle goes deep away from our visual point of view. The occipital horn goes towards us posteriorly. Next to it, the corma and monis, the hippocampal formation. So you need to be careful. And if you now lift up the choroid plexus, you find the choroidal fissure underneath it with the fornix running under it and the pulminar running in front of it. Now, vascular specifics for ventricular tumors can be broken down into two supply types. They're supplied from the ICA through an anterior choroidal artery, forming an anterior superior pedicle to the tumors. And then there's a posterior supply type coming from the PCA, sometimes the basilar tip, sometimes the P1 segment, forming posterior choroidal arteries, which can be split into medial and lateral portions. Now, if you look again at the trigonum, they are supplied, as I said, by anterior and posterior lateral choroidal arteries. Think about the superior pedicle coming in from the top. Think about the inferior pedicle coming in from below and supplying the tumor from two ends. And I think this is where CTA, CTV images are really helpful. And if you can, you should rotate the images in a 3D mode so you get a better orientation about the best access corridor to get control over these vessels. If you have a chance, occasionally get a tumor that was studied for stroke symptoms like this one. There was a perfusion study done for the smaller ventricular meningioma, and it shows you how vascular supplied these tumors can be. You see the inferior pedicle coming from the lateral end of it, and the posterior medial choroidals pointed out here, and you see the superior pedicle coming in from the top of the choroid plexus. So these are pretty hypervascular lesions and not always calcified. From the venous perspective, the trigonum is largely drained by superior and inferior choroidal veins, and then intraventricular veins. There are through 3 directions of venous drainage. You can think about draining anteriorly towards the septum, draining superiorly and medially towards the thalamus-striate vein, and draining inferiorly and posteriorly in the ventricular veins and the veins of the occipital horn. And you will see that in a second. Nowadays, I get tractography for many of these lesions and tumors because you get an incredibly well high resolution image, and you can see what's your displacement of the tracts, and that allows you to decide where's your visual compromise going to be and where's your potential risk for motor function. So I highly recommend, if you can get DTIs, to get that too. The resolution these days is fantastic. Now I want to show you the right-sided lateral ventricle lesion, a relatively small lesion, 2.5 centimeters in diameter, not asymptomatic because we had in a trapped temporal horn. This was the image we showed, homogeneously contrast enhancing, occupying the medial portion of the ventricle. This is not so difficult from a surgical perspective because you can roll this tumor nicely around. You can actually see it quite well. So I decided that this is a good approach. How do you come in for this one? I prefer on the right side a superior parietal lobule approach, and ideally you pick a sulcus that allows you to gain access deep into the white matter. You can take out, by image guidance, a bone flap, make a corridor of about 12 millimeters, and resect these lesions essentially with impunity. It's very safe. It's very familiar to most of us. We do this for lots of reasons. So this is the best approach to practice first time. I don't like to come in from the right side, middle temporal fossa, and middle temporal gyrus so much. Your risk of fiber compromise is higher, and because the motor fibers are deep to it, there's a higher risk for actually motor weakness post-operatively. Now look at this for the left side, completely different kettle of fish. The tumor is somewhat larger. Patient presented exactly the same way, just having a bit of a headache and word finding difficulties. On the CTA and CTV, you see that the internal veins are nicely displaced medially, but there's an inferior pedicle rising into the tumor, and then there was a superior pedicle coming down on the tumor. You can see on the MRI T2 images, there's a beautiful T2 cleft around the tumor that allows you to work around this tumor and roll this tumor in the ventricle. So here, I got pre-surgical DTIs and fMRIs because it's the dominant hemisphere, and you see how nicely the fiber tracts are displaced. And it also shows you there's a corridor getting into this from the back, and there's a CSF cleft medially. So this would be probably a good corridor to get there. I then flipped the patient 3/4 prone, came in from a parasagittal transoccipital sulcal approach, and was able to take this tumor out through, again, about a 10 millimeter corridor. Postoperative MRI scan with DTI and DWI shows you no vascular compromise, and you can get a gross total resection in most of these lesions very nicely on the dominant side. Now, in a very large tumor, this is a completely different kettle of fish. So this was a case I did this month of a middle-aged woman that came to me with this 7 centimeters by 5 centimeters by 4 centimeter lesions occupying the trigonum on the right side. And here, I think you need to really plan the surgeries well, because a very large tumor is very hard to take out through a very small access corridor. So obviously, this is not a case that is suitable for endoscopy. I do an incision, almost like at Fraser's Point is my best access corridor on the right side, 5 centimeters above the inion, about 3.5 centimeters to the side, but I make a relatively large bone flap because I want to see the best available sulcus, so I can do an intrasulcal dissection that gives me about another 2 centimeters of depth. And then the actual dissection of depth is only 2 centimeters through the white matter to get to the atrium. So I think you have a very short dissecting distance, which makes this again very safe and very familiar. Now, you really want to pay attention to the surface veins when you pay attention to choosing your access corridor. So watch out where Trollard's vein is located, especially on the dominant side, and where your left-sided Labé's vein is coming on, because you want to find something in the middle and not sacrifice surface veins. This is this particular patient's CT and CTA. You see that the tumor is partially calcified at the surface like an eggshell. Then there's a very hypervascular area inside the tumor that is contrast enhancing. And that's where a vascular pedicle is coming in from anteriorly. And you have to expect some significant blood flow through the tumor if you go to this lesion. When you now look at the CTV, you see there's an enormous vein draining anteriorly towards the septum. There's a vascular pedicle superiorly coming in from the side, supplying this tumor. And there's another ICA supply, best seen here on the axial support, coming in from the anterior choroidal, supplying this tumor. So this is a tough challenge because you have anterior supply to the tumor from here, you have posterior supply to the tumor from there. So you can't see this through a single viewing angle. So I labored a lot through this case and thought about how can I really approach this? And then I decided, okay, maybe I can split this tumor into multiple steps. And my best access corridor would be again where the tumor reaches the surface and there's a sulcus. So I was seeking transsulcal access to gain access to the long axis of this tumor, and then think about how I would be able to see the top of the tumor as well as the inferior posterior lateral side of the tumor, because I wanted to see the venous outflow at the end of the resection, but the arterial intake at the beginning of the resection. So that's really important. In this case, I also got a DSA that showed you right-sided ICA supply from the anterior choroidal coming in here. As the tumor extent is dotted line, then right-sided ICA supply came in sort of more laterally, whereas the posterior vascular pedicle came actually from the opposite vert and then split between both PCAs, large tumor blush with very large vessels over the surface. So I was pretty scared of this tumor because on the venogram, you can see there are pencil-sized veins draining that thing anteriorly going towards the midline, which matches my CTV image, which I obtained preoperatively. Luckily enough, the internal veins and the thalamostriate veins were deeper located and pushed in and down, so I didn't have to worry about that part. What did I do in this case? I decided to position the patient sort of lateral with the head somewhat turned prone. So this is me now standing behind the patient looking into the screen. And I wanted to find a sulcus here on the surface to split this nicely. This is sort of my schematic diagram of what I was roughly looking at. So I'm standing towards the occiput of the patient, the nose is pointing away. And then to gain some space, I give everyone my Crani cocktail, which is 100 grams of mannitol, 20 of Lasix, 10 of Decadron. Then I hyperventilate the patient to shrink the vasculature, and I elevate the head of the patient so I have good venous outflow. This gives you maximum room to work inside the cranium. And this is what I think it is. If you really think about this, you can learn so much in neurosurgery about what you do in the kitchen. I think this is just like peeling an onion. You just have to do it inside out, which is a little bit unusual. So I'm going to take you through these steps because this onion represents for me exactly what this tumor looks like. There's a pedicle that comes in from below that feeds this thing. And then somehow there's tumor growing in multiple layers. And then there's a huge draining vein at the top of it that I need to somehow get to because the flow is from here to there. And the idea is, can I create a window? Can I enlarge that window? Can I then take layer by layer to deepen my resection? Then I piecemeal this tumor. Then I decore the tumor. And once I have a shell that is so thin that I can fold the skin towards the resection cavity, my small corridor will be good enough to allow me to resect this. So these are the still images. Think about this again being the cortex. You want to find a sulcus that allows you to gain access. You want to make a little opening in the tumor, which is this part. So I've made the sulcus split. This is about 12 millimeters or 15 millimeters in diameter. Then I expose the surface of the tumor that is smooth and shiny and relatively firm. And I make a square incision here to take out the outer shell. Sometimes it's a capsule, which is a bit calcified. And then I resect this piecemeal, painful, one step at a time, because the CUSA didn't work for this. This tumor was fairly firm, and I just had to go at this one step at a time. Took me about 5.5 hours to do it, but I want to time lapse this for you a little bit. So the idea is, once you have made your square box in the middle, you then go in concentric circles and take one layer of this tumor at a time, remove it piecemeal with your micro scissors, and create a hole in this tumor. You decore the tumor, as I call this. The next step would be you pull in the wall from what you had just created. So this is now the decore tumor. You extend it by segmental resection, as I call this. So you create like quarters of the tumor shell, and you make the tumor wall visible. I actually use the Bovi to incise the tumor because I know it's totally safe in this area. I've exposed the surface. There's nothing that can go wrong here. Then I use micro scissors to chisel this out, and then I take one tumor block at a time. So you reach from an incision that decores the outer shell of this, and you take one segment at a time, and you make it deeper and deeper, one layer at a time. So this is your strategy to go into this. Once you have created a shell where only an upper portion of the tumor towards the venous outflow is maintained, you decore the inner side so you can roll the tumor towards this cavity. So I pick this end and pull it inward, which means there's traction towards the left upper visual field and counter traction with this retractor to create visual space. And then I can roll the tumor in the other direction, and I find the superior feeders, which are illustrated here. I take down one feeder at a time, and now I've created a left-sided upper segment. So as you can see, I take the right segment out, create space, and then I roll the tumor towards the right, and I can look over the tumor. This is segmental resection I was talking about, with the idea that traction goes inferior lateral, exposing the vascular pedicle superiorly. Next case would be this. I've now created a big cavity. I can now lift up the lower portion of the tumor, take another segment of this decoring system. And this is the most important part I'm going to show you in a video clip. There's a large attachment to the choroid plexus here, which you need to carefully dissect off, because you cannot pull on the choroid plexus. It will bleed pretty badly, and you want to have a visual field that allows you total control over your surgical site. Now, last part of the tumor is the superior segment, and this is important because I was very afraid of the venous outflow. So I create, again, a large segment that is the top shell here that I want to attack now and take out. And as I pull the tumor down, you can see this in this little pictogram, the venous pedicle will be superiorly, and you see these incredibly enlarged veins running over the surface of the tumor and then running medially. So you see the tumor drains surface near up and makes a squiggly curve, and then somewhere here is the septal vein. And it turned out that there was a venous aneurysm that made me very concerned. So I was trying to figure out, where's my venous outflow actually located? And I sort of was able to identify a neck between the choroid plexus and the tumor vein, and then that septal vein that was dilated, bulging into my surgical field. So I cannulated the vein and then placed an aneurysm clip and separated the vein anteriorly, the deep veins, from the superficial veins draining the super tumor surface. And at that point, I was able to deliver the entire tumor that was disconnected from all three vascular pedicles and pull it out. And this is the final end of the resection. Remove the last superior tumor segment in toto. You see the aneurysm clip superiorly with the septal vein dilated above, and you look into the ventricle, into a large cavity. Now, at the end, you line the resection cavity with Surgicel. That's basic, and you fill it, but this is the postoperative scan. The tumor is completely removed. The aneurysm clip sits right next to the septum anteriorly, and you can see that we did a fairly good job. This is the Surgicel slightly tinged with blood. And I get these CAT scans with the patient still asleep. So post-op management, Decadron, blood pressure control tight. I keep the blood elevated, the head elevated, and I keep the patient NPO. I keep this patient asleep for 36 hours to get the MRI scan first, because you have so much decompression done to the brain that when this patient coughs, the venous pressure that goes up in your brain with every single cough will put so much pressure on my resection site where I took the vein out that I was afraid of this may slip. And I just wanted to make sure that this wouldn't happen. These are complications that can occur if there's blood running into the ventricle. Obviously, you may have a little bit of bleeding in the ventricle. I'm not shy in taking the patient back to take this out. I don't wait for this because you never know whether it's active bleeding versus passive bleeding. So this was the tiny right-sided tumor we had seen before. And I just took the patient back this first night to clean this out, and it was just fine. So thank you for now. Let me try to switch over briefly and just share a video clip if I can get there. The question is, where am I? All right. So I hope that this is the right screen. So I want to briefly show you number 4. This is why my system died. It's like 50 gigabytes. So this is the resection of, oh, I pressed the JPEG, sorry, wrong picture. So this is this piecemealing of tumors that is really tedious, and yes, it bleeds and you need to go after it. And if we speed this up a little bit, you can see that you remove it like one piece at a time to take these segments out to achieve a proper decompression. Then you widen your resection.
We don't see any videos, Ek.
Oh, you didn't?
No. You could see your file, but then you clicked on it, but we didn't see anything.
Well, let me try again.
Yeah, yeah, it's on the screen now. It's not playing it.
This is the JPEG. This is the problem for me. Let me close it. If it doesn't work, this is not it. I apologize. This was a bit of a...
If it doesn't work, we'll make another webinar for you there.
Yeah. Okay. I can stop at this point. I, have plenty of other options to go into crazy details, but this was a challenging case for me, and I think it highlights nicely the challenges we face in this.
Thank you. I think it was a great case and very formidable case, and also it was quite amazing. Also for us to think from your side to the kind of steps and the planning you did, so much of strategy and well thought out plans. So such a comprehensive pre-operative planning, I thought, and also the conceptualization. And one question I have is, you've seen some of these branches from the AC, the internal circulations. Were any of them embolizable at all or not?
So I've had many intraventricular tumors at this point in my practice, and I've never found a endovascular surgeon who can cannulate the anterior choroidal to go all the way down to the tumor. They're always afraid that if you take down the anterior choroidal, you also take down the knee of the internal capsule, right?
Yeah, but this one wasn't anterior choroidal. This was slightly more from the posterior circulation and some from the...
Yeah. But as of now, both my endovascular neurosurgeon and neurologists have said they are not able to cannulate this for elective embolization. That would make your life so much easier because it dries up the tumor. That I think that's a great idea, but as of now, it hasn't worked yet.
Well, and anyway, I don't know whether anyone's got any further to add or questions. This was partially calcified, and I understand why you could not use the CUSA that much. I remember one similar case where I tried the debrider the ENT surgeons use in a large olfactory meningioma. I used like a debrider where it's got a hole on the one side and it sucks the tumor in and it cuts it. But you can only use in the middle of the tumor, not to go to the periphery. It's going to be quite risky.
No, exactly. I'm very afraid of the surface of the tumor and the energy you dispose basically when you get to the surface. And I thought, I don't understand the venous outflow here well enough. I don't want to run into the problem that it bleeds behind the tumor and I can't get there yet. So I bite the bullet and, you know, do it for 5 hours, which is exhausting, but it gives you total control over the field.
I agree. Thank you. Shall we go on to the next one? Before we go on to Abusa, we have Professor Paulo Codri back in the panel, and he mistimed the webinar. So he will be speaking to us after Abusa's talk. But just so that every participant knows that will be one more talk after Abusa. Ek, you want to invite the next speaker then?
Yeah, I'm really happy that Abusa Gunga from Turkey is going to join us, also talking about tumors in the ventricle. He works in a beautiful setting of neurosurgical anatomy lab, and I'm expecting some fantastic pictures of you. You always prepare your lectures really well. So Abusa, the floor is yours.
Can you hear me?
Yeah.
Okay. Okay, quite. I want to thank you. You almost explain everything about the approaching the atrium. Because of this, I mostly pay attention to the anatomy and what method works while I approach, and I will focus on the transparieto-occipital sulcus and the medial interhemispheric approach. I have no conflict in interest. As everybody knows, there is a complex white matter anatomy just under the cortex to the ventricles. And how we describe the eloquent areas and these white matter tracks preoperatively with functional MRIs and tractography. And intraoperatively, we get these functional regions with direct electric stimulation. And when we want to approach the ventricle, we must know the anatomy of the surface anatomy. For example, with medial surface, the atrium corresponds to precuneus and the cuneus just posterior to the splenium. And from lateral side, it corresponds to the supramarginal gyrus, posterior part of the temporal gyrus, and the anterior part of the occipital lobe. And when we start the fiber dissection, first fibers, U fibers connecting the neighbor gyrus, and when we continue to dissecting SLF2 and SLF3 observe. SLF2 starting from angular gyrus to the frontal lobe, and the SLF3 comes from the supramarginal gyrus and goes to the triangular gyrus. And what is the relation with the atrium? They are located superlateral to the atrium. You can see SLF3 and its relation with the operculum, and SLF2 here, and their relation with the atrium. Atrium is located medial and anterior to the limb. Everybody knows the arcuate fasciculus in dominant hemisphere is related with the most of the functions about the language, and it's covered the lateral surface of the atrium and the temporal horn. As Eckhart showed, it is difficult to reach laterally in dominant hemisphere to the atrium. If you damage these fibers, any kind of aphasia can be appear. We are looking from superior. You can see its relation with the atrium and the whole ventricle. It is related just lateral to the atrium of lateral ventricle. Middle longitudinal fasciculus described recently, and we don't know its exact function, but it is independent on its location and the connected areas. it might be responsible for the processing the special features of the sound, and also it's related with the lateral surface of the atrium. As you see, we are looking from superior, and you can see the middle longitudinal fascicle and its relation with the atrium and the cortex. And inferior fronto-occipital fascicle connects the frontal lobe to the occipital lobe, and it is the ventral semantic pathway with inferior longitudinal fasciculus. And if it damages, the semantic paraphasic can be seen. And you can see its relation with the atrium of the lateral ventricle, and inferior longitudinal fasciculus located a bit under the atrium of the lateral ventricle and lateral to the atrium of the lateral ventricle. And you can see the relation with the cortex and the atrium. We are looking from the superior. You can see the fronto-occipital fascicle and its relation with the atrium of the lateral ventricle and the cortex. We are looking from the inferior to see the inferior longitudinal fascicle, and you can see its relation with the atrium of the lateral ventricle. It's just located lateral and under the ventricle. And also anterior commissure fibers just located lateral to the atrium. As you see, we are looking from the superior, and you can see that it's cortical relationship and relationship with the ventricle. And most of you know the optic radiation and its trajectory. It comes from the lateral genicular body and goes to occipital lobe. Any injury can have a visual deficits can happen, and you can see its relation with the ventricle. It covers the lateral wall of the temporal horn and the atrium. Any direct approach from the lateral surface injure the optic radiation. We are looking from the superior side, and you can see its relation with the atrium of the lateral ventricle and the cortical relationship. And we are looking from the inferior side. You can see its relation with the atrium and temporal horn of the ventricle. And at the medial side, there are SRF1 supralongitudinal fan connected to the parietal lobe to the frontal, and the cingulum it connects to supracallosal cortex and anterior part of the hippocampal gyrus. As you see, the cingulum like in the lateral surface arcuate fasciculus, and their relationship with the ventricles. You can see cingulum and the SLF1. They are located superior to the atrium of the lateral ventricle. And also corpus callosum and their fibers related to atrium as a forceps major. As you see, it is located medial surface of the atrium of lateral ventricle. We are looking from the superior. You can see the callosal fibers just under the cingulum. And also you can see here the forceps major just located medial to the atrium of the lateral ventricle, and its relation with the atrium. And also thalamic radiation just located lateral to the atrium and the other parts of the ventricle. As you see, lateral surface is there are more white matter tracts than the medial side. As you see, this is fronto-occipital fascicle, anterior commissure optic radiation, and the internal capsule fibers. You can see also these fibers. This is the optical radiation, inferior fronto-occipital fascicle, anterior commissure fibers, and you can see the atrium form there. As you see, it is not enough to know the white matter thorax anatomy, and you must know the eloquent areas. For example, this is the regions only related with the language in the dominant hemisphere. And many approaches have been described to approach to atrium, as you see, posterior transtemporal, supracerebellar, transtemporal, posterior interhemispheric, posterior transcallosal, and posterior transcortical, which is directly to the parietal lobe, interparietal sulcus to the atrium. And you can see the fiber tracks which are related to each approach. And also, we just published some article to describe the white matter thorax when you approach from the lateral surface. In any approach from the lateral surface, optic radiation and optic fibers will be injured. For example, this is a small intraventricular arterial meningioma. We did via in a transsulcal lateral approach. And when you use a transsulcal approach, there will be a visual deficit. Because of this, I changed my strategy for this kind of tumor, arterial tumors, as use interhemispheric way. I always use ipsilateral sign down procedure, and this is the postoperative view. We have used the tracheonos just anterior to the parieto-occipital sulcus. Also, this is the ependymoma cases, and this is postoperative view. In these patients, we use endoscope, and without any cortical damage, we could remove all tumor. This is the postoperative view interhemispheric, and because of the gravity, you don't need the retraction. And also, we preserve all bridging veins during all this approach. Even it is a big tumors, you can use interhemispheric approach to remove. For example, you can see it seems thin before in preoperative period, but after removing the tumor, you can see the thickness of this tissue and the postoperative visual parameters. And lastly, we describe an approach with Professor Ture. This is the for us, this is the least invasive method to use parieto-occipital fissure to the atrium of lateral ventricle. Only we damage the inferior part of the forceps major, and you can see our enter point. And this is intraoperative view. Firstly, we describe the interparieto-occipital fissure with ultrasound, then put a cottonoid to describe the relation with the tumor. And when we describe the location of the tumor, we enter at the deep of the sulcus and remove the lesion. This is a carcinoma case, but also you can use in any kind of tumor and masses. This is the postoperative endoscopic view. You can see fornix, choroid plexus, and this is the postoperative view and the postoperative MRI. You can see only small damage with forceps major. You can reach this kind of tumor. And also this is a 3D model to show the what method works related with the posterior phareto-occipital fissure approach. You can see the forceps major fibers, and this is our entry point. Also, single fibers are preserved. As you see, you can reach any tumor in the atrium with this way. And also, you can see our surgical perspective intrahemispheric. You can reach this region to the temporal horn and the frontal horn. And also, this is the endoscopic view of a specimen. With this approach, what can be seen, as you see, this is the choroid plexus, forceps major. You can see also frontal horn and the temporal horn, and also tail of the hippocampus can be seen. And also you can reach the anterior part of the temporal horn of lateral ventricle and the anterior part of the frontal horn. And also intraparietal sulcus approach to preserve the optic radiation. It is some of the best way, but we recommend intrahemispheric way, but also you can use intraparietal sulcus approach to preserve the optic pathway. Also, this is the frontal horn of lateral ventricle. And also, this is the optic radiation and forceps major. And you can see our trajectory to the atrium of lateral ventricle via intraparietal sulcus approach. This is the endoscopic transparietal sulcus approach to the atrium. This is our endoscope. And we also used their entry point to compare the intraparietal sulcus approach and the medial posterior intrahemispheric transparieto-occipital fissure approach. This is the bulb of corpus callosum. When you enter via intraparietal sulcus approach. And also you can see the choroid plexus, frontal horn, temporal horn. You can reach any lesions located in these areas with these both approaches. And also, as you see, all structures can be done with this approach. Also, these are our models which can reach via internet and neurosurgical atlas. We published all these. And also you can reach these informations from our articles. And if you want to join our team, you are welcome to come in Yeditepe University Armut Neurosurgery Laboratory. And this is our laboratory, our archive, and our working stations. And microscope. I want to thank all my colleagues, Yaşar Gelture, and lastly, Professor, and thanks International Academy of Neurosurgical Anatomy. Thanks for listening. If any questions, I can answer.
Just fantastic anatomy. That was really beautiful. Thank you.
All right. Okay. Thank you. Don't think there's any further questions. Imad, you want to go back to the first session, and you're muted. We can't
Muted,
hear you.
Imad.
We cannot hear you.
Imad, you are muted.
Well, I won't deserve to be a moderator from being late, but you conclude by giving the last lecture from Dr. Kadri. He would be the last to conclude. He is from Brazil, very well scientific work he has done. He has his own lab, collaborator, and he's working on his book on white matter, actually. And that's why I put him first session. But we will conclude with white matter, I think, on glioma. So Professor Kadri is with us now. And if you allow Ramesh, he can proceed with his.
Yeah, sure. Go ahead, Prof. Kadri.
Thank you so much. I'm so sorry, I misunderstood the hour. I understood 12 o'clock here in Boston. But sorry, thank you so much for the opportunity. I don't know if you can you see my screen?
Yeah.
Okay. So we're going to talk a little bit after the beautiful lecture of Professor Gongor on the surgical anatomy to the region located in the mesial temporal regions. So if we think about the regions that can occur in that, they are mainly discussed about epilepsy. It's the hippocampal sclerosis and how to remove that safely. Now, whenever we think about our surgical approach, we do have to think, where is this lesion located? When we think about the mesial temporal region, or the temporal region itself, there is the lateral component, what we call the neocortical component, and the medial component, that what we call the limbic component. In the limbic component, we do have to pay attention if the lesion is to be located more anterior or more posterior. Lateral component mainly coming to the surface, and this is the only example that we're going to see. If we face a lesion located laterally, your natural approach is to be through the surface laterally and remove the lesion. Now, in the case where the lesions are located medially, you do have to consider the extension of this lesion. If it's more anteriorly, more posteriorly, or if it's combined both of these. So here we have an example of a lesion that is located only in the amygdala. While in this case, we do have a lesion that is located in the amygdala and extended posterior along the hippocampus all the way to the tail of the hippocampus. So these are two different lesions, one located anteriorly, another one taking both of the compartments, the anterior and posterior compartments. Now, whenever we think about a lesion located in the mesial temporal region, we can think also as lesions located inside the temporal horn. So these are completely encased by parenchyma, cerebral parenchyma. There is no natural way to get inside the temporal horn. There is the choroid fissure, but the choroid fissure is not really on the surface or surgical accessible without we go through one of the walls of the temporal horn. So if we think in any approach towards the temporal horn, we know that we're going to have to pass through the cortical surface, through the white matter, and then reach the cavity itself, which means that we are going to cut, we are going to sever, we are going to pass through, we are going to damage the parenchyma. We know whenever you want to discuss a surgical approach that we need to have the maximal exposure with the minimum trauma. Minimum trauma we can translate in less neurological deficit. And we do know also that white matter seems to be more sensitive than the neurons itself, than the cortex, and they will take you to a more long-lasting damage. So if we think about the temporal horn, most of the discussions that we have, they are based on the optic radiation. Since the description of Cushing, we do care mainly about the visual fields. However, we are going to see, as we already saw in the previous lectures, that there are a huge component of fibers and structures that can be involved. Optic radiation is just one component of the posterior thalamic peduncle. So whenever we are dealing with the lateral or the temporal lobe itself, we know that we have involved memory, language, and emotional problems that we can have through our chosen approach. Now, we can divide this approach according to the surface that we're going to enter through. They can be the lateral, through the sulci and gyrus on the lateral surface. We can call them inferior, mainly through the inferior surface, through the parahippocampal, or through the fusiform gyrus. And we can do what we call the transfusion approach, which are mainly through the amygdala, so we can also call transamygdalar approaches, which are the classical approach described by Professor Yassagui, and one variant of this that we call the transankle approach. I'm going to pass quickly through this because I already saw I presented those. So the first layer, doesn't matter which one of the approach that you're going to face, will be the cortex. Then once you remove the cortex, the U fibers all over the brain, less developed on the medial, on the limbic side, more developed on the lateral neocortical side. Once you remove these, you're going to see the superior longitudinal fascicle, as was already showed before, around the Sylvian fissure, and you can further divide that. If you remove the insula cortex, you see the extreme capsule, the connections of the extreme capsule, especially when you're going to do the transfusion approach, you're going to cut some of these fibers. If you remove the external and the extreme capsule, you're going to see on the ventral aspect at the limb and insula, the two other long association fibers on the lateral surface, that will be the uncinate and the occipitofrontal fascicle. Once you remove those, then you're going to face the association, the commissural fibers of the anterior commissure. They will fan out through the temporal, mainly, most of the time. We imagine that they come mostly anteriorly, but they also fan out posterior, towards the posterior portions of the temporal lobe. Once you remove the anterior commissure, then you're going to face the projection fibers. The first layer of the projection fibers are the temporopontine and parietopontine, and then when you go further deep, you're going to face the inferior thalamic peduncle and the posterior thalamic peduncle. The posterior thalamic peduncle is the one that do the characteristic turn, the Myers loop, which we know is mainly related with the optic radiation. But as I told you, not only the optic radiation. So this we can see the inferior thalamic peduncle and also the radiating fibers of the posterior thalamic peduncle. On the inferior surface, the main association fibers with the depth of the fusiform is going to be the inferior longitudinal fascicle. Inferior longitudinal fascicle, they have important connections of the occipital visual areas with memory areas of the limbic system. And then, different from the lateral aspect now, once you remove the cortex along the limbic lobe on the surface is the cingulate gyrus and the parahippocampal gyrus, you have not well developed U fibers, but instead you're going to face directly the long association fibers of the cingulate. Inside the parahippocampal gyrus, we have the two most important structures of the limbic system, which are the hippocampal formation and the amygdala. So most of the time, this is the goal, especially in epilepsy surgery, is to remove the hippocampus and the amygdala. Now, coming back to our concept, less maximal exposure, less trauma, once again, depending on the compartment, as I told you, the neocortical, the lateral compartment, of course, you're going to face or going to approach those lesions through the lateral surface. Now, on the medial, you do have to see or to think where is this lesion located. Most of the approaches, they come after the discussion about the epilepsy surgery, how to remove those. And the first one that you'll see is how much of the temporal you could see on the temporal lobectomies. Further, later on, we have Rasmussen proposing the removal of the hippocampus. But this, what we can talk or think as the archetype of our approach towards the temporal lobe, we can imagine that all fibers, they will gonna be cutted in the whole extension of those. And this will be the superior longitudinal fascicle, the inferior arm, the occipitofrontal, the uncinate, the anterior commissure, the temporal pontine, the inferior and the posterior thalamic peduncle, the tapetum, and the inferior longitudinal fascicle. The goal is to remove the parahippocampal gyrus with the hippocampal formation and the amygdala, and in this way you also remove the inferior segment of the cingulate. Then later, we have Niemeyer, the Brazilian, that proposed what we call the restrictor, the selective approach to the mediotemporal region that we call the transventricular approach. Professor Yashargil, to not damage the neocortical areas, he proposed the transsylvian approach to the inferior peninsular sulcus at the level of the limb and issue. Now, later on, we'll have a lot of variations, but interestingly, most of the variations is still focusing in the visual field defects on the optic radiation. Doesn't matter which one of the approaches you're gonna choose on the lateral aspect, but let's gonna use the middle temporal gyrus if it's the most discussed one. There are clearly advantages. You can get a good exposure, it's easier to perform, and you avoid the vascular structures of the Sylvian fissure. However, it's a long distance, you require long incisions, there is the need of retractions, and you're going to pass through the neocortical areas to reach one limbic area or arch or polycortical areas. Now, if we think which fibers you're going to be severing on the lateral approach, more or less extension, of course, of them, but still, you're going to cut all of them as if you do a lobectomy. Qualitative, not quantitative, but in a way or in another, all of the fibers of the lateral aspect will be cut, with the exception of the inferior longitudinal fascicle. Now, with the exception so of the inferior longitudinal fascicle. And as we told you, the goal is to remove in all of the approaches the parahippocampal gyrus. Now, in the transsylvian approach, if we use the approach of Professor Yashargil, we will not need retractors. You're not going to deal with the neocortical, and you easily or precautionally early, you're going to have control of the vascular system as well as release of the CSF for brain Odysseus. The disadvantage that you do need to know well your anatomy is technically more difficult, and especially if the lesion is extending posterior, your access is most limited anteriorly. Now, Professor Yashargil did it through the amygdala, and as long as you are confined by the amygdala, you will not have damage of the projection fibers. So you do not expect it, as he didn't have in his series, you do not have expected to have any visual field defect. But you're going to cut fibers of the uncinate fascicle way less than what happened in the temporal lobectomy or to the lateral approach. You're also going to cut fibers of the anterior commissure, as well as your goal is to remove the amygdala, parahippocampal gyrus, or the hippocampal formation, and also you remove the cingulate. The transuncle, it's a variation of the Yashar-Gill approach that is supposedly to go more anteriorly. Technically, it's more difficult and more restricted anterior. One of the things that can improve your view is if you combine a cranio-orbital approach to get the better route for this vision. Undoubtedly, it is more restricted anteriorly. You should combine with a COZ sometimes, but in this case, your entry point is directly the amygdala, and you preserve all of the other fibers as long as you are confined to the amygdala. Now, inferior aspects or inferior approaches, you can use the subtemporal, but the subtemporal route has as advantage mainly the retraction of the temporal lobe and a potential lesion of the complex of Lappe. You can decrease this risk by using the supracerebellar transtentorial route as proposed by Professor Ture and Professor Oliveira, and this will clearly give you the whole preservation once you are getting directly to the target that you want to remove, which is the parahippocampal lobe. There is no need of retraction, and you can have adequate exposure posteriorly and anteriorly. There are disadvantages. You do need to know very well this technique, and especially for patients, for teams that are not usually to use the patient in semi-sitting position, because otherwise it's technically more difficult to use this route. On the other hand, you will have the fully exposure of the temporal horn without cutting or damage any of the fibers not directly involved with your goal. In this way, if we can summarize lesions located anteriorly in the amygdala, we would favor a transsylvian approach, which you can use the transuncal approach or the Yashar-Gill approach through the Sylvian fissure. And you can remove the whole lesion without compromising any of the other parts of the neocortex of the temporal lobe. If the lesion has an extension more posterior or combine it, like this one that we see here, that extended with the parahippocampal gyrus all the way posterior, then we would favor the inferior approach through the same sitting position in a variation as proposed by Professor Ture, where you don't put the patient really in a very sitting position, but likely between 20 to 25 degrees with the head up. One of the characteristics of this is that you really flex your neck, which helps you to get better exposure and also decrease by increasing the venous pressure, decrease the chance of air embolism. In this way, you can gain further exposure from the most anterior portion, as here you can see the amygdala, all the way towards the tail of the hippocampal formation without damaging the other portions of the temporal lobe. And you can see here the patient after the surgery with the full resection of the lesion. I tried to be fast, so I again apologize by being late, by mistaking the hours. And again, I'd like to thank you for the invitation and opportunity to be here with you. Thank you.
Thanks very much. Thank you. That was a brilliant talk. Especially the dissection, the specimens were so amazingly clear, and this is something which I think it's what makes you think the possibilities of this particular study of fibers to lead to minimizing the morbidity associated with such approaches. So thank you, Prof. Kadri, and I just want to know whether someone like Abida or Busa want to make any comment on it.
We
Hello,
are
Professor Kadri.
Yeah.
A wonderful lecture. I completely have beautiful pictures and beautiful fiber dissections, and he's
Oh,
covered.
you have better. I'm seeing your work. You have much better than me.
No, and he's shown with each approach which fiber you will cut. So that's just a beautiful presentation, you know.
Thank
So you would choose the right approach for the right lesion and avoid major damage.
Abu sir.
It's one of the things, of course, right? It's not only this, but one of the things that you have to consider is for sure this anatomy.
Yeah, the final comment from Abu sir.
Also, I have the same opinion with the Kadri and the Abida. We always recommend supracerebellar approach to reach the mesial temporal region, and for atrial regions, we use always interhemispheric way to preserve all white matter tracks. Thank you, Paula and Abida and the other lecturers. Thank you very much. I learned a lot of things again.
Thank you. Thanks very much, Prof. Kadri. And I'll hand over to Prof. Kanan for the final concluding remarks.
Okay. Thanks, Ramesh, for moderating this session with EC. I'd like to thank all the speakers for their marvelous presentation and contribution. It adds values to this webinar, and I'm sure young and established neurosurgeons equally will benefit from such presentation. I'm looking forward for the next webinar in 2 months, and I hope I will meet you all in person, perhaps in Belgrade or in Cape Town. And these 2 meetings, we are planned to have sessions of the IANA there. And if somebody got more interested from the invitees, they are most welcome to join us. Vladimir, I think
Vladimir is left here to go.
Okay, I'd like to thank Vladimir to direct that sessions, and all the speakers again, and have a good day or evening or night. And Professor Kadri, nice to have you with us on this session.
I apologize again for the mistake in the hour. Sorry.
We all got confused with this GMT. Even the people sitting in Europe, they keep asking me, what is GMT? Is it 1 hour behind or 2 hours behind? No problem, as long as you have gave a nice presentation. Thank you. Thanks, everybody. Stefan, and I'm seeing Dr. Victor Hugo with us. Hi, Victor.
Yeah.
I left, I think, and Dr. Girish, first time with us on webinar. Wonderful to have you as well. Thank you.
Yeah, it was a great opportunity for me. Learning experience.
Wonderful.
Looking forward to more meetings. I was just getting the hang of it, how it happens. So, yeah.
Wonderful.
Okay.
Thank you so much.
Take
I'll
care.
see you
Bye-bye.
later. Okay,
See you.
bye-bye.
Thank you.